and welcome also to everyone who's watching online. My name is Harry Coulter-Pinner. I am Director of Research and Engagement here at IPPR, and we are the UK's leading progressive think tank. So we're delighted to be here today on what is a really important occasion, a really exciting occasion. It was 2 years ago, almost to the day, where we hosted our last State of Health Care conference in this very room. And the world in that time has transformed beyond all recognition. The pandemic has tragically taken 5 million lives across the globe. It's created a huge economic and social disruption. And it's also put extreme pressures on our health care system and healthcare systems across the world. And in that time, IPPR has pivoted its health and care research to really respond and help policymakers respond to that really challenging context of trying to make difficult real-time decisions about how we manage a crisis like the pandemic. So we've run surveys of patients and staff to really understand how people are experiencing the crisis, and made recommendations to government and to the NHS about how it can maintain world-class health care services throughout the pandemic. And we've worked also with our analytical partners, Carnel Farah, to really understand the disruption to non-COVID services and how we can start to recover for people who are suffering things like cancer, mental health and CBD. But we have now reached a really crucial moment where we really need to focus on how we start to build back better, how we look beyond the immediacy of the crisis, and how we build a stronger, better health and care system and a better and stronger society. And the real question is how we turn the rhetoric of government around Build Back Better, around levelling up into a reality. At IPPR, we really pride ourselves on coming up with bold, but also tangible, practical, deliverable solutions to the big challenges we face, and never has an agenda needed those bold but deliverable solutions more than Build Back Better and levelling up, which are high, lofty aspirations, but aspirations that need grounding in a real plan for delivery. And so today's conference, today's discussion is about helping us define what we think Build Back Better should look like in health and care and how we're going to go about doing it. And to help us, we have some amazing speakers joining us today, from Matthew Taylor, newly started at NHS Confed, through to Dame Jane Dacre and Lord Gus O'Donnell, and of course all of you in the room and all of you online. I think it's fair to say we have the kind of intellect and the experience in the room and online to answer those questions, so I think it's going to be a really exciting day and agenda to try and do that. Before we kick off, a few bits of housekeeping just to bear in mind. First, a big welcome to everyone who is on Zoom and watching this. You can join in and ask questions, and we really want you to do that. So please do send those in, and we will be monitoring those channels to make sure that your ideas, views, questions are fed into the debate. For those of you in person, it's great that everyone can be in a room. I'm not sure how much longer we'll be allowed to be doing this. So I'm really delighted that we're here today in person. Just a reminder, if you could continue to wear masks if you're comfortable to throughout the session, just for everyone's safety and protection. We've spread out the seats a bit so that it should be reasonably socially distanced, and the windows are open. If it gets too cold, tell us. We can temporarily close them, but we want to keep them open interspersed across the day just to keep us safe. And for the panelists, just to say that we've got a really packed agenda, so we're really looking forward to hearing your views, but do keep to time, because I don't want us to keep people too late this evening. Finally, I'd like to say a huge thanks to our sponsors at IPPR and the Better Health and Care Programme, in particular to GSK, Gilead, AstraZeneca, AbbVie, Siemens Healthineers, and CF Healthcare Consultancy. Without their support, we wouldn't be able to be here today, and we wouldn't be able to do the work that we do. So we're really grateful to them. We're also really, really grateful to HSJ who are partnering with us for today's event. And finally, all that's left for me to say is thanks to the team who organised this, because I may not be here at the end of the day. So I want to say thanks to Chris, to Path, to Victoria, and also to Emma, Robin and Olivia, who've made it all possible. In particular, the hybrid nature of events these days makes them doubly complex. So we're hoping all the tech goes right today, but if there are a few hiccups, just bear with us because it's a new challenge we're all having to face together. So without further ado, over to the first panel, which couldn't be a more important or more topical conversation. So how can we make progress on inequality? And COVID really has exposed the scale of that inequality. Our very own Victoria will be chairing today's session, and we also welcome Shirley Kramer, who's Chair of British Future, former Chief Executive of the Royal Society for Public Health, and Guppy Bowler, Consultant Strategist focused on building economic democracy and former Interim Director of MEDAC. So over to the panel to kick off today. Thank you very much.
Hello, hi, welcome everyone. I'm Victoria Poco-Manfo. I'm a researcher in the Work and Welfare State team at IPPR. I'll be chairing this panel today alongside Guppy and Shirley. So, of course, I'm really, really excited to be joined by two public health experts who'll be giving a presentation on their thoughts on public health and inequality, and then hopefully we'll have time at the end for 15 minutes for a Q&A. So as Harry said before, we've packed lots into the agenda and we want to keep the timing. So I'll have to be quite strict with the presentations and with questions, and so that we can just make sure that we get to hear from everyone. So to my left, we have Guppy Bowler. Guppy is a strategic consultant, educator and organiser committed to health justice. She was formerly interim director of MEDACT and is co-founding of Decolonising Economics. To my right, we have Shirley Kramer. She is the former CEO of RSPH, which is the Royal Society for Public Health, and is a trustee of Alzheimer's UK. And she serves on the board of the Food Farming and Countryside Commission and is on the advisory board for IPPR's Better Health and Care Commission. So many of you will know that IPPR, we're constantly thinking about public health and inequality, and it has risen up the political agenda over the past 18 months. This was brought into a clear focus during COVID-19 as the pandemic disproportionately impacted deprived communities, people of colour, and we saw increasing deprivation. Our research has shown that poverty is a key driver in the rise of depression for over 1.3 million people. Cuts to public health budgets in the Midlands and the North has contributed towards widening regional inequality. And finally, the NHS charging system continues to put migrants at further risk of COVID-19 through unequal and inaccessible policies. So we know now more than ever that these concerns are integral to Build Back Better, and we know now arguably more than ever that our health is interlinked to the communities that we live in and the people that we work with. So I've put together a research question. It would be really great if you all could sort of think about this research question as you hear from Shirley and Guppy, which is essentially, how is it that, having all of the evidence that we've got over the decades, which overwhelmingly shows that this is a concern for healthcare, that health inequalities have still remained really stubborn. And we've seen that's been true of all the governments. So why do you think that is, and maybe what kind of action do you think you'd want to see to actually truly see some change? So I will now begin with Guppy. So go ahead, and I'll have 5 minutes.
Great. So hi everyone, thanks for joining. I'm going to just begin, rather than go through the data and evidence, as Victoria mentioned, there is an infinite amount that shows us a picture of worsening health outcomes for a large number of people getting worse over the last decade. We can go into that in a bit more detail, but I really want to focus on some of the key tenets of public health and just use that to explore some of the ideologies and approaches that have been taken and that could be taken in order to address this challenge. I thought that might be so whenever I speak about health inequalities, I always want to begin by reminding us that health inequalities are defined by the difference in health outcomes that are both avoidable and unfair. Avoidable and unfair because they are ultimately the result of political choice and decision. those differences are often described as the difference between the least deprived and the most deprived, because our health is so connected with our access to wealth and resources and the kind of conditions in which we live within. And as Marma described, yes, we've had a lost decade of lives and ill health, but we've also, over the past decade, lost essential public health infrastructure that's sought to address these injustices. And why have we lost them? Well, I'd argue that because health inequalities are explicitly interrogating the political and social and economic conditions in which ill health is created, that practice of public health is also explicitly political, which is why it shouldn't be a surprise that the demise of Public Health England in the past few months, being transformed to the newly established Office for Health Improvement and Disparities, makes absolutely no reference to health inequalities, because the government is making a very clear message that they do not want to have the responsibility or be held accountable for addressing health inequalities. And that is something that I think very few of us have really clocked onto, and something I want us to remember for the remainder of this day. Instead, the government strategy for 2020, the 5-year plan for Public Health England, committed to tackling big structural issues of ill health, recognising that they exist, by investing in technology that would help individuals inform their behaviour choices. We know that we cannot effectively do this at an individual behaviour change level, because unhealthy behaviours are not the origin
of consequences in people's lives that enable them or disable them from making the right choice around their health. And many illnesses occur because we live in an environment that either limits our capacity to act or actively drives us towards ill health. So the message from the government we have is that whilst they know that this is a problem, they're definitely not here to help us. And rather than investing in infrastructure that can keep people safe, the government are committing to this individualized approach, which fits neatly into our contemporary neoliberal economic mindset, in which the individual is touted as the key economic unit of economic success, failure, and responsibility. And yet, when I was rereading these notes, this is a little bit of a telling off, but public health policy practitioners, researchers, and heads of institutions are still very nervous about talking about power. They're creating a vacuum in which public health expertise is becoming more and more irrelevant in the context of the political system that we are working with, and are unwilling to innovate to meet the political demands of this moment. And so we keep seeing this increasing gulf between communities, and at the same time, we are feeding into the neoliberal mindset of personal responsibility by sometimes talking about the NHS, the care system, as the only place in which health is influenced. Talking about this myth that in the UK we have a universal healthcare system, when actually there are significant barriers to many, many people to access healthcare. We demand additional funding, which is incredibly important, but we forget that this money is actually going almost directly into the hands of private companies rather than being circulated within the public health system. We always fall into this narrative around people getting ill because of their own behaviours, and we seem to be unable to escape that dynamic. There is an increasing and worrying conversation around some people being deserving of care and others undeserving. There is a real fixation of medication as the only medical or the only intervention that is available to people. This, our commitment to the vaccine over actual public health measures that could prevent the pandemic from spreading, and any and all other forms of prevention methodologies. And we refer to social determinants of health in an incredibly passive way, that people just happen to live in bad conditions, that they just happen to have poor housing, that they just happen to eat bad food, rather than looking at what powers are driving those conditions. And so, got 1 minute? Part of the reason that we're stuck in this pattern is that I think that traditionally arguments and reasons for investing in public health interventions came very much from the idea that investing in public health is good for a healthy workforce and was needed to create a profit-making economy. But that seems less and less relevant in an age where actually the workforce is being automated, and actually being ill is very profitable for many, many companies. And that for me seems to be a bit of a problem. So if we wish to continue within this system of thinking, any of the systems that we design or the policies that we design will continue to contribute to lost lives. I feel like I have got a lot more to say on how we can address that, but I do also recognise that we haven't got time, so I'm going to pass on to Charlie.
Thank you so much. That was really, really interesting. I'm really interested in the idea of sort of personal versus collective responsibility and putting the responsibility on the patient rather than the institution. So that was really great, and hopefully we'll hear more from you with the questions. So over to you, Shirley.
Thanks a lot, really. Very pleased to be here to see all of you. So I'm going to start with what's the state of health inequality? Well, yesterday, the Office for National Statistics said that from March 2020 to November 21, the number of excess deaths above that 5-year average in England and Wales was over 128,000. We know that these deaths weren't equally distributed across the population, but obviously fell heaviest amongst the poorest and most disadvantaged. We have one of the worst records in excess deaths. Another report published yesterday, and this is how quickly the reports are coming, by LPC, called Hidden Health Needs, estimated that the total numbers waiting for healthcare were currently 13.6 million, if you include those who haven't come forward due to the pandemic. So it highlighted in that report too that there are large and persistent geographic inequalities with both known and hidden NHS waiting lists. So piling on the data. Of course, we have an aging population, one of the oldest and poorest housing stocks in Europe. And at the start of the pandemic, we already had a decade of stalling life expectancy, fragile and faltering welfare state, inequalities in jobs, housing, education, unequal access to good food, inadequate transport, and poor early years support. All these factors are social determinants, contribute to this unequal health and this massive 19 years difference in healthy life expectancy between the poorest and the wealthiest, despite said having a universal system which in theory should support all equally. So of course these factors led to the same decreased exposure around COVID-19, mortality rates twice as high for people from the 10% most deprived local areas. And the Health Foundation did a useful report in July 2021, The Unequal Pandemic, showing that since the 2008 financial crisis, our public services have been eroded. So we were starting in a really bad place. And I'll remind you that 40% of all the deaths were care home residents, and 6 out of 10 who died in the beginning were actually people with disabilities. So our inequalities have got considerably worse, but they're also more visible, more debatable, and the public are concerned, according to the Health Foundation's polling, that something needs to be done. So is this the crisis that's going to harken a new age of equality? Why haven't we made progress when there have been so many of these detailed reports? And 90% of what's the public's health sits outside the NHS. So one of the reasons, I think the main reason we haven't made progress has just been mentioned, and that's around individual responsibility. It's your fault, you smoke, you're overweight, you've got an insecure job, you live in a poor housing. This is a pervasive view, particularly on the right, but it's constrained our state-led intervention in many structural areas. And the other thing I'd say is we've often seen a lack of consensus on solutions. We're looking for the simple when we need to have integrated, holistic, long-term, and simultaneous action in several areas. So just very quickly to take food as an example, food policy, we don't have it really in the UK. It's a good example of our failures. We have the twin issues, obesity and hunger, 2 areas of inequality which have been prevalent in this era of COVID. Researchers in Cambridge show that between 1993 and 2015, 689 separate obesity policies. And yet among the adult population during this time, obesity rose from 14.9% to 26.9%. Levels of hunger also increased. So for 3 decades, we've had these similar and failing policies, and any ideas on structural interventions have been voluntary. So we've piled guilt on individuals where obesity is determined to a large extent by environmental factors, socio and economic inequalities, and our failure to tackle ultra-processed food. As one commentator said to me, we should regulate the market, not blame the consumer. Food's got a low priority in this country, the policies across 16 different departments. There is no single place to find out about food policy, even inside government. We shouldn't be talking about obesity policy, but food quality laws, junk food control, taxing and regulating ultra-processed food, for example. Henry Dimbleby this year produced the National Food Strategy, which was hailed by almost everyone as a breakthrough because he looked at the food system as a whole. And he provided that integrated plan with recommendations to keep us healthy, halt climate change, support farmers, and support nature. We need an agreed vision on what healthy eating means and around all these areas of inequality. Affordable healthy food has to be the default option, and we need a way of monitoring how well we're doing, perhaps a Minister of Food to coordinate all the areas of government. So cross-government working on a health inequalities framework needs to be monitored closely, it needs to be independent across the long term with local government and local investment and autonomy to build up our communities. This would offer a better chance to level up sustainably.
Ooh, that was fantastic. That was right on time. Yeah, thank you so much, Shirley. I really like that Minister of Food idea as well. So we have some time now, just over 10 minutes for questions. I'm hoping to do one round of questions, so 2 from the room. Hopefully, I've got 1 online as well. Emma is walking around with a mic, so if you just raise your hand and can point to you. Yep, straight at the front there.
I'll do without a mic. I'll speak loudly.
Just for the, because we've got a virtual audience, we'll need you to use the mic.
Point that it's okay.
Just for the virtual audience, yeah, thank you.
Okay, you know, the point that Shirley made about obesity. Now, this topic has been discussed over the years, but there's no action whatsoever. And I did notice today, we said there are 16 departments, but there's no collaboration between any of them. Now, I went to quite a huge food and health conference at the Excel Center in 2018. And there was a lot of emphasis from consultants from various hospitals asking the NHS that it's no point just putting tax on salt and sugar. You need to get the supermarkets, the food industry on board with you, because without that, nothing is going to change. And how did we're in 2021?
I couldn't agree with you more on that, because one of the reasons I think the National Food Strategy, which came out this year, has gone down really well across the board, is because the stakeholders involved in it were all the big supermarkets, a lot of the producers, farmers, the NFU, people like me in the public health sector, but people like Bidvest who run the logistics, so the entire system, because that's what we need to be looking at, to provide good food for all, and taking into account things like climate change, nature, and farming, because we need to ensure our farmers are paid properly for what they're growing, and are they growing the right things in the right place? We don't have a land use strategy. So these are all the things that are really going to help make us well if we can have the appropriate affordable food.
Yeah. So I'm going to move on to the other questions, because we've got 2 online here, and I don't know if there's any more questions in the room here. If there's not, I'm going to move on to someone called David Quinney online. So he was asking, what kind of framework, and this is to both Guppy and Shirley, what kind of framework do we need to ensure the accountability of public authorities in achieving the right speed and scale of progress in addressing, I think, HR? I'm not sure what that stands for.
Addressing health inequalities.
Yeah, health inequalities, there we go. Okay, so in the current system, whatever that is that enough? And then the second question from Marley, so one of IPPR staff, so on the NHS charging, how do you think the system of NHS charging for overseas visitors and migrants has impacted on health inequalities, particularly over the course of the pandemic?
Yeah.
Go ahead. Two big questions.
Can I actually also just quickly refer to the question on taxation as well? I mean, for me, this maybe feeds into a little bit of changing of systems that we need is that a tax on certain kinds of food is important because it's an indication around what is, what the market is willing to invest and divest from. In the same way with fossil fuel subsidies, like we're trying to there's many different kinds of taxation that need to exist, and removal of subsidies for food that is basically like fossil fuel heavy and cheap and bad for our health, and we need to rebalance that. So I think there is a role for different forms of taxation we play, but as everyone mentioned, it needs to be kind of coherent across the board. In terms of framework for state accountability, I'm like particularly nervous, particularly from the last year and how things have changed at a structural level within public health, the underfunding of local authorities and the responsibilities around public health, how poor the services are, the loss of expertise from different levels of government. And there are some recommendations I make in the paper I wrote last year, but when I look back at them recently, I feel that they're also now outdated, given that Public Health England has been deconstructed. And what I feel is lacking in this kind of, if the state's not taking responsibility or holding any form of accountability within its own agencies, and we can't rely on private companies, what is the other alternative? And for me, I feel that policymakers, think tanks, researchers should be much more invested in community-based approaches towards health protection and safety. And there are different mechanisms, kind of what I was going to refer to, that we should be really thinking about, that seem radical, but actually are like very practical. So ideas of abolition, of climate justice, of thinking about how to have control of our own environments, about having the resources to make the decisions to have control of our own environments, about the food that we create. And they seem small and local, but with investment from different places other than the state, they could actually have quite significant impacts, not just on the material needs of people, but also their empowerment, their feeling of self-worth, their own self-determination. And that is so much more significant in a society and a culture that is at the moment incredibly violent and harmful to lots of individuals. And on Marley's question, worked on this paper with Marley last year, so I'm happy to answer it. The immigration system and the way that immigration enforcement and borders has leaked into so many parts of public services that creates such a level of fear towards communities that are already fearing accessing services because of the risk of being deported or being tracked by the Home Office involving the police, has created a place through the pandemic where people are not willing to get vaccines. And there are communities who have been historically marginalized by the state who won't go to access to vaccines because of course they are feeling nervous about and are distrustful of what that means. And it doesn't seem like this particular government is going to change anything around the way they talk about immigration or migrants or racialized populations. And so that's just going to have a continually knock-on impact in terms of people accessing the care that they rightly deserve and need in order to keep themselves safe and everyone else safe.
Thank you.
Here to what you just said, is what I can say. Perhaps I'll talk a little bit about measurement and what I was talking about monitoring in the long term. So for a long time, I mean, we only care about what we measure, don't we? So we don't measure things that they don't seem to matter. And I really like, and many others do, I'm sure in this room, the New Zealand model, where you're looking and you're saying that health is this asset, health is wealth, and that you're measuring how healthy is the population. And they have developed this in New Zealand. I went to hear the guy who had helped develop it, who's used to be here in the Treasury, is now, I think, finance minister or something like that in New Zealand. And they have a whole section of really targeted measures so that every 6 months they can say, how are we doing on health and well-being of our population? It is across departments, so that departments actually have to talk to each other about how they're doing. Just as I was mentioning on food, they have to actually, there's winners and losers a little bit here, but the health of the population is what we're aiming for. We could take some of those ideas, and already the ONS, the health index, our previous CMO, Professor Sally Davis, wrote in her last report about the health index, about having an index which highlighted where we were going in the health and well-being of the population. There are people already doing it here. We really should make this policy. We should have it independently monitored. I really think the government particularly this government can't be marking its own homework. So that has to be independent.
Fantastic, thank you. I'm going to do another round. Is that okay? Yeah. So, is there any more questions in the room? Amazing. Yeah. With the mic, Emma's just going to come to you with the mic. Yeah. Just one more question. I've got one more online. So I'll do one virtual and one in the space. Yeah, go ahead.
Sure. So it seems like so far we agree that this is a problem that should be mainly solved by policy, mainly solved by the public sector. But I also wanted to ask how much of the role does the private sector have to play in this, i.e., how much do companies care? And if they don't care, how much do they be incentivized to care?
Fantastic. I'm just going to repeat that question. So what is the role of the private sector and how can they be incentivized to care? Thank you.
Did you want to answer the other one as well?
Oh yeah, that's a good point actually. So, and the second question is, in the context of food inequality, how do you think the state should or shouldn't cooperate with organisations from the third sector, like food banks? Yeah, up to you both.
Well, I might talk about the first bit on incentivized to care. I think quite a lot of companies have woken up to the things they need to do. And I think that's partly to do with climate change, and other things are now knocking on from that, including inequalities, including the brazen, horrible inequalities from COVID. One of the ways that I think is really good incentivized to care is an organization called Share Action, which you may or may not have heard of, which talks to shareholders and says, you know, don't invest in these companies because they're doing X, Y, Z, in the same way we might have approached tobacco in years gone by. So the big 9 food producing companies are really on the hop for Share Action. They've been, you know, talking to them. And I think putting that in the public domain as much as we can about those that are doing really well and those that are doing not so well, because often that will affect the share price, and money talks, as we know. So that's one area. And I think the general cultural way we behave and think, if we show we're caring about these things, then the companies will care too, because we're all consumers. So I think we should do more in this area. So I'm really glad you asked that question, because I think there's a lot more we should do. And having worked more recently with some of these companies around the Food Farming Countryside Commission, I can see that a lot of them are really struggling to work out how to do this and what are the ways to do it. And so it's very useful to engage in proper debates with them, and not to say, well, you're the bad people over here, to actually talk about the whole systems as we go. And we haven't, again, done enough of that.
And I just want to agree with Shirley on that point, is that I think that one thing that also influences private companies is social movements. And I think we can see that a lot with the recent decision for Shell not to invest in Campbell oil fields, and the point that climate change has actually got on many, many businesses to really consider what else intersects with the climate crisis is ultimately everything. So, you know, our food, our housing, our transport. And so many businesses that we rely on a day-to-day are thinking about those intersections and how they can address those problems will also remain relevant within the context of that today and the future. And I think although there is a slight contradiction with, you know, how to remain relevant and profitable, in that when we also want to find ways to move our economy to have different forms of indicators around sustainability, around happiness and well-being as well. But it is a starting point. And on, can you just remind me the question on food?
So in the context of food inequality, how do you think the state should or shouldn't cooperate with organisations in the first sector like food banks?
Yeah, I mean, they should allow organisations like the Trussell Trust to be able to speak quite openly and clearly about the structural problems and barriers to people accessing food and the reasons as to why people are having to increase use of food banks. And I think there's a problem around organisations that rely on a little bit of public funding, or who are openly challenging some of the policies and decisions that government have made, and then being demonized by government themselves because of their existence and the requirement for them to exist in society. So the government could potentially just be a bit more human, have a bit more humanity around their existence, and use that for a bit of self-reflection on their own political agenda.
Thank you so much. And that is the end of this panel. I'm not going to be able to ask any more questions, unfortunately. So I'm going to thank you so much to Guppy and to Shirley. That was really a fantastic, really amazing conversation. And I'm going to hand over to Harry to introduce the next speaker.
Thank you very much for a really interesting and important conversation. I'm delighted now to welcome to the stage Matthew Taylor. Matthew is Chief Executive of the NHS Confederation, a former Chief Executive of the Royal Society of Arts, the RSA, and before that he led Number 10 Policy Unit and perhaps most excitingly IPPR back in the day as well. Described as one of the brightest policy thinkers of his generation, we're really looking forward today to hear some big policy ideas about the NHS and how we build back better in this kind of precarious moment we find ourselves in today. So Matthew, I would love to welcome you to the stage to speak to us.
Great, thank you very much. So it's great to be here. I've got slides and I'll try to remember to use them, but I've only recently started using slides again after not using them for about 25 years. And that goes back to an IPPR conference where we launched to the world our Commission on Public-Private Partnerships, which was very controversial at the time because it suggested that the private sector could have a role in providing services to the NHS. In fact, I had dinner with Alan Milne the other day, and I was reminding him that when we produced that report, he condemned the IPPR for the idea of the private sector to provide searches. It's interesting how things go around, isn't it? Anyway, we had the world's press, I think it was live on TV, and I had asked, a good paid intern in IPPR to do the slide deck, but I think they'd had incautious use of the spell check. So the first slide went up and it said daft recommendations of the IPPR Commission on Public-Private Partnerships. I've desisted from using slides, so I'll try to remember to use them, but it's just not my natural métier. So I want to talk about is, I'll say a little word about, here we go, can't do it. I'll say a little word about the Confederation, just so you know who I am and what I'm doing now. So the Confederation is the organisation that represents all the different bits of the health service. So we basically network, mental health network, primary care network, acute network. So we represent leaders from across the health service. We're an advocacy organisation, public sector advocacy organisation. Now, if you're a public sector advocacy organisation, it's a bit like being the kind of the slave, the 1980s punk bands I used to listen to that only really had two chords. So if you're a public sector advocacy organisation, you have two chords, and those two chords are give us some money and leave us alone. And I can spend most of my time on the media finding different ways of saying give us some money and leave us alone, but actually that's not enough for reasons that I'll go into in a minute. It's not enough for us to be an advocacy organisation. We have been an improvement organisation, but I'm determined that that's much more what we become, an improvement and ideas organisation, as well as an advocacy one, which is why I'm delighted that we're talking to IPPR about working with you on your forthcoming Health and Care Commission. So I want to talk today about what I think are the kind of big shifts that the NHS needs to accomplish over the next few years, or starts to accomplish over the next few years, if the health and care system is to get back on track and is to progress. So that's what I'll focus on, but I ought to say something about where we are right now, I guess. And where we are right now is very, very difficult. We face, I think, the toughest winter the NHS has ever faced. This is a combination of a number of factors, the impact of the decade of austerity, which has left us with a depleted workforce and with similarly depleted capital stock. So that left the NHS in a weak position. We've always had an NHS strategy of having as few beds as we can possibly have. So we have fewer beds per per citizen than most other countries. So that also undermines your resilience. You then add in COVID now, and although there are fewer patients in hospital with COVID, still those patients, a lot of them are in ICU, and I'm completely failing to make this work. This is my comment on today's political events. Clearly, this is the big issue of the day. Don't have a Christmas drinks reception is my advice to you. I have no idea what happened there. I'm going to go off piece now. So I knew this would happen. So, it's fine. I'll just really, I know it all. It's fine. You know. Yeah. It's much better without slides. Who needs slides? Great. So we face that. Then we've got COVID, and then we've got 2 years of built-up demand. And that isn't just expressed through the number of people waiting for operations, which is a huge issue, of course, but it's the people who have not sought medical help or haven't had medical help and who are now, for example, tragically turning up in emergency departments with very advanced conditions. So you've got all of those things coming together, and it's going to be an incredibly tough winter, and we just have to hope that Omicron does not take off, or if it does take off, that the symptoms are very mild for everybody. Those hospitalization rates are starting to go up, and get hospital rates going up again. That's very worrying. So it's going to be incredibly tough, and we're calling on the government simply to say that there is a national emergency and to have a very, very clear message. And the problem about Christmas parties, to be honest, is not so much the kind of morality of it all, but it just blurs the message when the public needs a really, really clear message right now. And we hear that we're going to be moving to some version of Plan B. Well, I guess that I think is a good thing, because really this is not a time to be taking any kind of health risks at all. Beyond that short-term challenge, the second challenge we've got is the elective backlog, which has kind of come to the front of people's minds as the number one challenge for the health service. Now, it's an incredibly important challenge. I don't think it's the only important pressing challenge beyond COVID, but from what I understand, the review that the government has set up, the Mackey review into that elective backlog, is likely to argue for what looks like a fairly Blairite set of measures. So making it easier for patients to travel to get quicker treatment, strengthening payment by results for hospitals so that they're actually encouraged to expand the work they do if they have got greater capacity. Now, as a Blairite myself, I have no problem with that. It may indeed be the best way to address a very specific challenge like the elective backlog. But the problem we've got then is we'll have that set of ways of working running in parallel with the creation of integrated care systems, which is a very different model, which is a collaborative model, collaborative both in terms of providers joining together in collaboratives, but also also at the level of health systems as a whole and places as a whole. So I think a growing question mark is it possible to pursue the elective recovery plan, as I understand it's likely to shape up, at the same time as pursuing what seems to be a very different kind of ICS strategy, integrated care system strategy. So we will see how that unfolds over the coming period. And as I said, I don't think the elective backlog is the only thing that is going to be a kind of very high priority, because we've also got a major and very worrying deterioration in cancer treatment times. Sometimes a statistic just jumps out at you, doesn't it? And I think that the two statistics that really jump out to people at the moment are ambulance waiting times. And it's just terrifying that you may have to wait hours and hours and hours yourself or buy a loved one to get an ambulance. But secondly, the fact that in many places now, fewer than 50% of patients are getting to see a consultant within 2 months of having a likely cancer diagnosis from their GP if possible. And that's, if you imagine the level of anxiety you're feeling in that period, and it's going on, and you're worried that your health is deteriorating. So there's a lot of those things that the things that Labour chose as being the key national targets, they were chosen for a good reason, because they were the things that the public care about most, and those things are going to be fought. So how do we address those key targets at the same time as setting up this kind of this system? So that's the second issue. So the short-term challenges, and then this kind of question of how you get back towards some of your targets at the same time as setting up integrated care systems. And then the main thing I want to say, though, is to think about even beyond that, and it is an incredibly complex and difficult time, what are the shifts that we need to achieve? We need to demonstrate that there's some progress on. And I think the opportunity for the opposition parties will be that in each of these areas, the very most that will have happened in the next 2 or 3 years is some progress. And so there's the opportunity to have a cogent story about how you accelerate progress in each of these areas. So the first is workforce. And now the rate limiting factor in many places in health services workforce. It's not actually cash. There are parts of health services that have got quite a lot of cash because of the money that was put in for COVID, particularly if they don't have that many patients with COVID in their hospitals at the moment. But it doesn't matter that they got more money because there's no one to spend it. There's no one to spend it on because of those factors that we've seen. Brexit, of course, is a significant one, but it's not just Brexit, it's the underinvestment, it's the failure of workforce planning. We haven't had a comprehensive workforce plan for the NHS since 2003. Which is why it is, by the way, that Simon Stevens and Jeremy Hunt and others are pressing for amendments to the NHS and Care Bill to demand more regular and public workforce plans. Of course, the Treasury does not want regular and public workforce plans because they come with a very obvious price tag. So we need an approach to workforce, and that is about fundamentally, it's about planning, it's about recruitment, it's about retention, it's about work in the health service that fits around people's lives. But it's other issues, it's about the quality of work in the health service. And also thinking more radically about how we might do things differently. So for example, I think there ought to be a common entry route for people at the bottom of the health and the care, the beginning of the health and care career, a common entry point into all health and care jobs from which you would then move on to specialise, for example. We've got to utterly change the way in which we view care as a form of work. The idea that care is minimum wage precarious work is, well, we are paying the price for that failed thinking. So workforce. Secondly, system integration. Now I'm immediately rushing off after this event to go to one of a innumerable number of Whitehall roundtables to discuss the integration white paper, which is one of a growing list of white papers which has been put on the back burner, but we are expecting it in January. So there's going to be an integration white paper. The Prime Minister has made it clear that his one big idea in this space is that he wants a single person accountable for integration outcomes. I think the trick is how do you do that without a massive reorganization, without merging health and social care, which would be impossibly difficult to do right now, undercuts the agenda of the existing health and care bill. So there'll be something around integration, and we can get obsessed by the kind of systems and the processes and the structures, but critically, in the end, integration is fundamentally about how do you build services around people? How do you build services that empower people? How do you build care pathways from the moment you pick up the phone to phone the GP right through to hospital and then back into your day-to-day life, hopefully cured or with a plan to manage your condition? And really, we're still just not very good at building services around people. It's as simple as that. And as Charlotte Augst, who is brilliant, I hope we'll involve her in the work of the Commission, the head of National Voices. She speaks very powerfully about the fact that most people's experience and interactions with the health service just does not empower them. I mean, remarkable statistics for the number of people on waiting lists who don't know why they're on the waiting list. They don't know whether they're on it for diagnostics or for treatment, or people who have long-term conditions who've never been given the most basic advice about how it is you manage those conditions. So service integration around the individual, fundamentally driven by the notion of empowering the individual. And in this space, I come back again and again just to a very, very simple diagram that I remember Jos de Blok, who runs the inspirational head of Berkzorg, the Dutch nursing care outfit, which is often cited by people because it's kind of completely non-hierarchical. Now that is one of the things that's interesting about it. Actually, what's interesting about them is their model. So when Jos draws his model of care, he puts the individual, the patient at the middle, then the family, then the community, and then the service he provides. And he says that the role of his service is fundamentally to empower and enable the community and the family and the individual. Whereas we have one which tries to avoid taking any responsibility for as long as possible and then pushes everybody else out of the way and provides a tiny sliver of care and then buggers off again. And at the moment, isn't even doing that because of workforce shortages. So we need integration of services absolutely with the individual, the family and the community at their heart. Then thirdly, We need system working, which is what these reforms are all about. We're in a very peculiar position, which is that we've got an NHS and care bill produced by this government, which I speak to Conservatives all the time, sorry about that, but I do. And none of them seem to have any idea what it is or what it's for. They have no enthusiasm for it at all. So you've got a government sponsoring a bit of legislation, which most Conservative MPs don't seem to understand. I mean, they'll vote for it, and that's fine. Now, that's okay, because it's actually a good piece of legislation. On the whole, there are problems with it. So we're creating these integrated care systems. And the critical objective there, I think, is to move from a system which incentivizes activity to a system which incentivizes outcomes. And related to that, moving from a system, the NHS is supposed to treat people on the basis of need, it actually treats people on the basis of demand, and demand and need are not the same things. So system working should fundamentally be about population health. It should be about using data to have a really rich picture of health outcomes and shifting the strategy in order that we improve those outcomes, which has to mean tackling health inequalities, and then mobilizing not just the health system, but other parts of the local system, local government, voluntary community sector, in pursuit of these kind of more holistic health strategies. So that's the system working there. Two more things. The fourth thing is innovation. Digital, data, med tech. You know, we live in this kind of parallel world, and when we talk about the NHS as it really is, and then we might go occasionally to conferences or read articles in Wired or whatever it might be, and there's this amazing future, or that we might see in the very best, most fully funded American bits of the American health system or Scandinavian health system, whatever. You know, the future is out there. It's unevenly distributed, as it's often said. So we have got to innovate. We saw innovation in COVID, but I think the interesting thing is what we've seen in COVID is the whole story of innovation. So if you take one area, so if you take virtual consultations, yes, massive progress, suddenly people going online or just even having telephone consultations, you know, and that's great, you know, suddenly that shifts. But the evaluation shows that for some people, the outcomes aren't so good. And we've had a public backlash when the public started to feel this was happening in order for GPs to, you know, bunk off from doing their work properly, which is a calumny, but nevertheless, one that got into the kind of public domain. So we have to innovate, but we have to innovate in ways which are both ambitious and realistic. One of the weaknesses of this government is the whole kind of moonshot kind of mindset, which is constantly asserting things which are then very, very difficult to deliver and end up with people being highly disappointed and becoming cynical about it. So yes, digital, yes, data, yes, medtech, enormous opportunities for change, but we need realistic ambition and investment in those areas. And we've also got to innovate in ways which on the one hand look at systems as a whole, because a lot of the reason why innovation fails is because it's not embedded in thinking about services as a whole. So care pathways, clinical pathways, for example. It's not just about gadgets and gizmos and more data. And secondly, again, we're going to have to think about this issue of inequalities, because one of the things that the future will bring is greater empowerment and personalization of healthcare. If you think of just one example, which is the current randomized RCT on the blood test that will identify the 50 most common cancers, if that works, if it is the case that we can all have an annual blood test that tells us whether we've got one of the 50 most common cancers, that will change an enormous amount. But we've got to think now about what it's going to change. What will we deal with if suddenly there's an awful lot more people presenting with early stage cancer in a situation where people are waiting a long time, for example? What will it do to people's general attitude to their health? Will they use the GP much less because they won't be worried when they have a symptom because they think, well, I had the test and I was fine? But also, what would you do about those people who are nervous about having a test like that, who for a variety of reasons don't want to engage in that way? So when we think of something really exciting like that, we need to think about it in the round, because it's a general rule of public services: the more you empower people, the more you increase inequality. Unless you do it in a very, very determined way to address inequalities. If you look at schools, we give more power to parents, more choice to parents. Middle-class people monopolize the best schools because they can move house and they can bring in tutors for their kids or whatever. So if the future for healthcare is more personalization and more empowerment, we have to do it in a way which doesn't exacerbate those already existing health inequalities. And then the final point is simply that we've got to win an argument about the role of health in the productive economy. And that's partly about that kind of system working I was talking about earlier on, notions of health as an anchor institution, health on the high street. But it's actually a broader argument, which is that, you know, not only is health the fastest growing global marketplace, not only is the health and care system the major employer in most places, you know, but actually, rather than this model that you generate wealth over here, you bring it over here and you dump it into the bottomless pit of the health sector, actually investment in health makes a significant contribution to our economy. The latest statistic I've seen is a quarter of the productivity gap between the lowest productivity areas and the highest productivity areas in Britain is down to health. So in some of the areas of the lowest productivity, you have shocking rates of people dropping out of the labour market with ill health, on average in their early 50s, for example. So we've got to win an argument that health investment is investment not just in the nation's health, but actually it has major benign economic externalities. And it's really important that we see health in the levelling up. Yes, another white paper that's been delayed. How many are there? But health as an important place in that levelling up white paper. So those for me, workforce, integration around people, system working, innovation, health as part of the productive economy. These are the 5 shifts which we need to make. And as I said, and I'll finish with this, you know, I think that, you know, whatever one's political persuasions, we can press for these things to happen now and be pushed forward now. And in many ways, like NHSE is pushing forward on all of those agendas, safe in the knowledge that the amount of progress we'll have made by the time we get to the next election will only be a small fraction of the distance that we need to travel, and that what the public will be looking for at the next election is which government offer seems to be the most credible in terms of accelerating these changes that I've described.
Thank you, Matthew. I think we're approaching 2 p.m. So in the interest of you getting to a meeting on time,
I can take 1 or 2 questions.
Okay, let's take.
I don't normally have questions on a fish.
There's a question down here on the right. Is there a microphone? The lady just down here on the right. And is there one other question? Or we'll take 2 at a time. And the lady at the back here.
So it's a technical question, I guess. So it's the economic ROI issue. What is the biggest barrier to us being able to demonstrate that an investment in health has economic impact? Great question.
And the lady, can you just put your hand up and so yeah.
So I haven't got much time to boost it. First of all, I don't think we've been asking the question. And secondly, it's a complicated question, but I don't think that means that we can't work at it. I think we absolutely can work at it, but it's just not, we've just thought we've tended to have the assumption that we should just view health expenditure as expenditure rather than as investment. And then how you work it out, you know, it's a new area and it's an area we need to develop. And it's the kind of thing that I hope that IPPR will be able to do more work on. So, yeah.
And the lady at the back.
I'm from MHA, the charity care provider. We're looking at some plans from the government that set out a 10-year vision for social care and some good stuff in there. But the age-old question about funding and how much we need to stand still as a social care sector, I guess I'm really interested to know how long-reaching your levels are about what the care sector looks like here now.
And I'm going to repeat the question because people on the online can't hear it.
I'll repeat it. Okay, great. So the question is the degree to which people in the health system that we represent understand the kind of challenges that care. Look, one of the things I was very proud of when I went to the conference is that we established the Health for Care Alliance. So we actually established a body of people from the health system who came together in order to argue for the importance of the care system and to support greater investment in care and reform for care. So absolutely, and indeed, both myself and Chris Hobson, who runs NHS Providers, which is sometimes I call our sister organisation, sometimes our rival organisation, depends what day it is. He and I have both argued in the last few weeks that if the government had more money to spend now, spend it on signing on fees for social care workers, or as some places are now doing, introducing the high now in order to try and keep. So yeah, absolutely. And you know, one of the biggest problems out there right now is that every hospital leader I speak to has got many patients, sometimes hundreds of patients in hospital who do not need to be in hospital. And that is because there is not the care provision for them outside hospital. And that's partly to do with what's been happening in our care homes, but it's also a lot to do with the collapse of domiciliary care. And as I said in my speech, you know, chickens are coming home to roost in relation to the way in which we've treated care. And that's, you know, we have to do things very differently. Thank you.
Thanks, Matthew. We could continue this conversation indefinitely, I'm sure, but we'll have plenty of time to do so over the next year or so. Because as Matthew's mentioned, we have plans afoot for commission. It's not yet announced. Matthew's sorry. No, it's fine. It's a tasty trailer. Right, I'm going to move on to this speaker because our next speaker. Let me see if I can get the screen to do what it needs to do. Are you going to do that? Those of you in the room, this is the bit of the day where the technology pressure is the highest because we have Gus O'Donnell joining us on the line. Fantastic. Is that okay still there? No, good. Great. So we are going to be joined now by Lord Gus O'Donnell, who is needs no introduction really, but was previously permanent secretary to the Treasury and then the cabinet secretary under 3 successive prime ministers. Gus is currently an expert advisor at Frontier Economics and a leading expert on behavioural economics and also well-being economics, and has spent a lot of time in recent years trying to shape the public debate around the need for a broader set of metrics to measure success in our economy and in our society. So as I said, this is the bit of the tech the day that Mike is the most challenging. Gus, can you hear us first of all?
Most certainly I can hear you, yes. Can you see me and hear me?
We can see you. We'd like to see you on the full screen. Give us 1 second. There we go. We can now see you fully. We can hear you. And so I think the technology has succeeded, which is very exciting. Gus was due to join us in person, but I believe you just come back from Canada. Is that correct, Gus?
That's absolutely right. I flew in this morning. So I am self-isolating because it's really important to obey the rules.
Indeed. You could educate some of our leaders on that one, I think, Gus. So we're gonna do this as a bit of a conversation. I'm gonna ask Gus a set of questions, and then we will also try and take questions from the room and also online. So Gus, to kick off, so pre-pandemic, GDP was widely used as the main metric of success in this country and also in the majority of countries across the world. What I wanted to ask was, what do you think COVID teaches us about the appropriateness, the applicability of that measure of success? And does it suggest that we should be rethinking how we measure success in society?
Absolutely. I mean, I think COVID was a great example of something that's always been there, which is that GDP, as an economist, I know, and as all economists will know, it's an activity measure, not a success measure. The guy who put it together, Kuznets, said, don't use this as a success measure when it was first started. I mean, the reason being that it just adds things up. So the good and the bad all get added up together. So, for example, during COVID, we had people volunteering to help in food banks. That activity there, volunteering, doesn't get picked up in GDP at all. If instead of doing that, they had gone on the streets, prostitution, illegal drugs, selling crack cocaine, that would all count in GDP. So it's weird, you know. I think GDP is a very kind of, it's all about activity, and it doesn't pick up things like the losses we all had from social interaction, you know. The absence of hugs just doesn't feature anywhere. The fact that people's mental health deteriorated doesn't show up. So yeah, it's a weird thing to, I say this as an economist, a weird thing to use as a success measure for society. Basically what you want is for people to have fulfilling, satisfying lives. And for people themselves to judge that that's what they're having. That's what's crucial, and that's what governments should be trying to do, not maximize GDP, which is just crazy, you know, and also has all sorts of other implications, like it leads to people buying lots of things and using up lots of resources, and doesn't pick up any of the climate change effects that we all know about. So there's lots and lots of reasons why you wouldn't want to use it as a success measure.
And so
and
what
COVID, I thought, brought those home to us.
And what would you propose as a replacement? What would you look at instead then?
So I think governments should commit themselves to trying to improve the quality of lives of their citizens. So in other words, their well-being, you know, how people feel about their lives, how satisfied they are with their lives, whether they feel their lives are worthwhile or not. Those sorts of issues should be what we're about. And it's a very democratic process then. You're not saying we are going to impose from above some success measure. You're saying, actually, we're going to ask people, do they feel that they are having satisfying, worthwhile lives? Those are the kinds of things that we should be thinking about. Yes, they're subjective, but that doesn't, we now have a lot of economic analysis, social and economic analysis, which actually tells us about the kinds of things that affect how people feel about their lives. And that tells us the sorts of things that we should be doing, and what governments should be doing, but also what individuals should do, and what companies should do, and what charitable sector should be doing. So it's a much better way of organizing things. It comes down to, like, George Bush had this thing about the vision thing, you know, and there are those who criticize certain political leaders for not having a clear vision. Well, this is the vision they should have, to improve the well-being of their citizens, you know, that's and reduce inequalities in well-being of citizens. Those are the things I'd say, and that gives you an amazing platform and tells you, you know, how to conduct policy.
So if we go back to 2010, obviously there was an attempt by the Cameron administration to put well-being, happiness into the agenda more. If David Cameron's administration had been successful, if that really had become the anchoring mission of governments, not just his own, but successive governments, what would have been different as we entered the COVID pandemic? How would we have experienced the pandemic differently, do you think, if that had really taken hold at that moment?
Right. So if and you know, I give David Cameron great credit for starting off the measurement process. The problem was really the follow through in terms of policies, as you implied. If they'd taken that seriously on policies, we would have done a lot more about climate change, for example, very, very much earlier. We would have done more about mental health. You know, we've talked about trying to give parity towards mental and physical health, but we haven't done much. And the fact is that mental health access to treatments is still terribly limited. So specifically with regard to what would we have done with COVID, well, yes, we would have taken much more seriously the government's own risk register, which I remember setting up with, it had pandemics in there. We had in the past stocks of PPE, for example, which were eventually used up because people were saying, well, there's no real output from these things. And what they were was preparing for a really worst case scenario, which is having a serious virus pandemic. So yeah, we would have done more in terms of prevention. And then when it came to the policies itself during COVID, you would have looked at, through a well-being lens, the kinds of issues like, should we close schools or not? You know, that, and you see the way that you look at the SAGE minutes and things like that, the way this is operating, and I've written quite a lot about this. There's a lot of the medics kind of giving you ideas about transmission, implications of transmission. But what we really needed was other disciplines around that table saying, yes, but what are the impacts on well-being for the kids of keeping them away from school? What are the impact on their parents? What are their long-term implications for their mental health, physical health as well? So they didn't have the right framework, which means that every time you come to think about an issue about do you increase lockdown, reduce it in certain ways, you need to be managing these trade-offs. You might be having a positive effect on reducing transmissions, but you might be having very negative effects on certain other things. So I think that's what was sadly lacking. And it still is.
Countries across the world have started, made more of a push, I would say, at changing the kind of levers of government and the systems of government in terms of putting well-being or broader metrics of prosperity at the heart of government. So you could look at New Zealand, which was mentioned earlier in our debate about health inequalities here today. Wales and Scotland have obviously also looked at things like the Future Generations Act and new kinds of national framework. How successful do you think those experiments have been, and how much do you think we've already seen what is possible versus actually we need to push much further just to see how this could and should work in practice?
Well, and I would add to your list Canada. So in their last budget, they had some quality of life measures which are starting to gain more prominence there. Yeah, we're seeing these measures being introduced. I think it's early to know whether they're going to make real differences and be able to tell what's happened in terms of policies. I think some of them, for example, you mentioned the Welsh one, give a particular importance to future generations. And I think that's, a well-being approach would say, well, we need to care not just about the well-being of the current population, but the well-being future population, which too often, in a kind of standard economic cost-benefit analysis, you'll discount that away. Because you'll use a high discount rate and actually means you care relatively little about the future. I would say if you're measuring things in terms of well-being, what's the reason for having less weight on well-being in the future than well-being now? I think there's a lot to be said, unless you believe that we're on this wonderful uphill route for well-being all the way through, which I don't, to be honest. I wish, but I don't. So I think those are other countries are paving the way. They all have their kind of pluses and minuses, which we can go into if you want. But I think they're a really important step forward for saying actually what government should care about is a whole range of issues which basically affect the quality of people's lives. And I'm very pleased with them. You only need to look at those countries which come out top in the World Happiness Index, which measures life satisfaction, and they surprise, they tend to be, 7 of the top 10 are the Scandinavians, New Zealand, Iceland, Netherlands. It's countries that really have, by their sorts of policies, tended towards a well-being approach, although not all of them use that language.
And just to push on kind of, you said we could look at the kind of pros and cons of all of them, and obviously we're all limited for time. But if we were to recommend now, if we were sitting with Boris Johnson right now or Rishi Sunak in the Treasury, and they were to announce one thing at this point, looking around the world, what would you point them to?
Oh, the one thing I'd say is I'll pick up that piece in Canada about quality of life. I'd say let's analyze our budgets by looking at how they improve the quality of life, and let's measure it by looking at people's subjective well-being. Fairly straightforward, and putting at the heart of it people's own perceptions of their well-being. I think the issue with the 4 pillars in New Zealand and other areas is that they still don't kind of tell you how you trade these pillars off against each other, which inevitably you have to do. So I would have that ultimate goal of improving people's well-being and reducing inequalities in well-being, and then let everything flow from that.
In a moment, I'm going to come to our audience. So do have a think about questions both online and also in person. But to maybe wrap up kind of from my questions, Gus, do you think there's more appetite post-COVID for a well-being approach? And what is it that's preventing us from really grasping on that opportunity?
I would say definitely. I think people have realised during lockdown, what really matters to them. We've missed out friends and family. We've missed out on social occasions. Obviously, there's been a change in people's spending habits. You know, we've observed a lot more spending on goods, a lot less on services, because you couldn't spend on holidays and pubs and restaurants and all the rest of it. So there's been that switch, and I think people beginning to realise that the pleasure you get from things is in some ways quite limited, and there's quite a lot of research now into this. But experiences and memories and those moments, where you actually get to come together with your family, having missed them for weeks and months, those things really matter, and we should be thinking about how we can work towards getting them back as quickly as possible. And I guess that is all about the vaccine programs as well as anything else. So, yeah.
Fantastic. So I'm going to come to the audience now, and I will repeat the questions back to you guys so you can hear them. So would anyone, first of all in the room, I've got some questions from online, but if people in the room would like to open up the questioning, please do put your hand up now, and Emma can come and bring a mic to you. So the gentleman in the centre here.
Hi. GDP living up, we've seen close to zero GDP per head growth over the last decade or more, which makes leveling up economically really quite difficult to achieve. From a well-being perspective, is it easier to achieve that leveling up, or do we still need the underpinning economic growth to do that?
Great question. And the gentleman on the right here as well, we'll take a couple at the same time.
The sound wasn't great for that first one, so maybe you can repeat.
Are better than GDP and very advanced, but I think the problem that maybe they both share is that they both encourage quite short-term statistics, i.e. they kind of concentrate on the present and they measure population at present. So my question is, how do we develop measures that encourage governments to 10, 20 years down the line when the best public policies might start to make an impact, when indeed there will be many other governments, other parties in power? And so how can governments get credit for that, and how can we encourage these sorts of policies?
So there were two questions.
Repeat those? Sorry, they didn't come through.
The first one was the degree to which you can level up well-being without delivering economic growth. So the point was made that it's very hard to level up economically without economic growth, but can you level up well-being without significant economic growth? And then the second was that both measures, well-being and GDP, might still lock in a kind of short-termism in politics, and the degree to which you can incentivize and create a structure of decision-making that really does encourage long-term policy-making that spans across governments.
Okay, so on the first one, leveling up, and can you do that without economic growth? I mean, obviously, if you're able to improve productivity, as it were, and increase the size of the cake, then there's more to distribute all around, and that's generally a good thing. But only if the cake's the right thing, if it's a genuine cake. I mean, you can increase GDP in all sorts of ways that actually don't allow things, more actual resources to be available to people. Like I said, there's all sorts of things in GDP which are bads rather than goods. So I think that you can do quite a lot on improving well-being, even as it were in a zero-sum game. So if we were to reallocate public spending in the right way, to spend a lot more on prevention rather than cure, to think about mental health is the most obvious thing where there's unmet need out there. We at the moment are somewhat obsessed with hospitals and doctors, and I think Nigel Crisp, who was the head of NHS in my day, basically used to say, look, hospitals are for repairs. Health is something that's much more important and covers everything else. So I think that's important. I would also say a focus on well-being at work would be massively important and actually achieves the two things that you want. We look at, as you say, GDP growth has been very limited for a long time now. Why? Because productivity has been so poor. What would increase productivity? Actually improving the well-being of your staff. There's a brilliant paper by Jan Emmanuel Deneve and others from professor at Oxford, who's done studies and looking not just at correlations, but at causation, showing that if actually your employees, and in this case, these are employees working at BT call centers, it's very practical, this, very down to earth, that when their well-being is higher, they are more productive. And you translate that through to the economy, and if we had companies that really concentrated on improving the well-being of their staff, they would actually also, as it happens, almost certainly improve GDP and their profitability. And I think that's important because everybody talks about the ESG agenda, and we're now kind of very obsessed about the E part of that. Well, I'm very obsessed about the S part, the social. And the first thing a company could do in terms of improving the S part will be to measure the well-being of their workers. A lot of people, again, COVID has helped this, because during COVID, you know, I chair an economics consultancy, Frontier Economics. We have, because we've had a lot of people working from home, got a lot of younger people who are maybe in flats, you know, the conditions at home aren't always ideal for working from home. And we wanted to keep a close eye on their well-being. And it's actually something you think, well, we should be doing that. And we've remodeled the office during the lockdown period to actually emphasize the creative and social aspects of work, as opposed to sitting in front of a screen bashing out reports. So I think there's a lot we can do here which improves well-being, and actually, as it happens, improves GDP. They don't necessarily need to be traded off. And of course, leveling up, you're absolutely right. If you think about the people who are at the bottom of the well-being scale, they tend to be people who are have mental health problems, first off, or out of work, or in a job that's really soulless job. So those sorts of things will be important. Income obviously matters at the low end. You know, let's not forget that. High up, after a while, it really adds very little, but certainly at the low end, it can be quite crucial. So there are things like that. Relationships matter a lot, and those are the things that were damaged by COVID quite often because people were kept apart. So all of those things, I think, you need to work on. And leveling up, you know, I could write it. I'm trying to persuade Andy Haldane to write it, you know. He's on the inside now. I hope he will.
And the question about short-termism, Gus.
Yes. Will it help counter short-termism? Short-termism is a kind of, governments do actually bizarrely do some very long-term issues, like sometimes they're ones I'm not particularly fond of, like HS2 and Hinkley Point C, but they do tend to make some large investments for the longer term. I've tried to look at whether this is related to the nature of our democracy and whether, for example, if we had longer terms of office, you would get more long-term governments. But, you know, you take New Zealand, it's 3 years. Which is, to me, very bizarre. So I think it would certainly help to have a long-termist view, which does, in a technical sense, come back to thinking about discount rates that you want to use for various things. The countries that are most successful in terms of happiness, like I said, those Scandis, tend to have when I looked at those top 10 countries on well-being, I was also doing a talk about democracy. Is democracy dying? And I looked at the top 10 countries according to the Economist Intelligence Unit on democracy. 7 out of the 10 were the same, and they were the Scandis, Netherlands, New Zealand, and Iceland. And I think there is something. Those systems tend to be much more proportional representation. And I think there is something about the quality of democracy and the involvement, which actually, and if you've got proportional representation, then you tend not to have those lurches, and there tends to be more of a consensus approach, which I think lends itself to more long-term issues being actually tackled. So I hope that partially answers your question.
Yeah, it's really interesting. We just published a paper on trust in politics, very timely paper, and that found similarly that the political system, and in particular proportional representation, has an impact on levels of trust, which I think probably is also linked to continuity of political project as well. A couple of questions to wrap up with from people online, Gus. First of all, there's a question about how we would make sure that in measuring well-being, we made sure that those who tend to be more excluded from our economy and society are part of that measurement, and that we weight people appropriately in that well-being measure. How do we make sure that, do we weight everyone equally, or do we bias the weighting to take account of certain groups of people? And also, I'm going to slightly shorten the question that was put online because it's quite a long one, but there's a specific question about whether you would still, if you were replacing GDP with well-being, how that would work in terms of trying to manage things like macroeconomic stabilization, or would you propose to continue to use the same economic metrics for things like that?
Right. So on your first question, measuring well-being, this is, I mean, you know, it's one of the classic questions about all of this. How easy can you do it? And in the end, the ONS did a lot of work, and we came down with these 4 questions, which are about life satisfaction, about worthwhile, happiness, and the negative aspect of anxiety. And there's a big pilot study going on now in Manchester. A good friend called David Gregson is running this with nearly all of Manchester schools to look at, can we reorient, you know, can we think about what it will be like in schools if they actually thought about improving the well-being of their kids, as opposed to how many get bloody A's or A stars in their exams, you know. And again, as it turns out, kids with high well-being do better in their exams. So it turns out not to be a trade-off, but you do if you get children with better well-being, they're more resilient and actually go on to have better lives. There's, again, very strong evidence of that from the work that Richard Layard and others have done on Origins of Happiness. So yes, there are some you know, so when they're looking at these things, they did have to deal with the question of how you ensure that everyone can handle, you know, filling in questionnaires and the like, and language issues about minority groups, and, you know, are you treating them, making sure that you're looking after those who are otherwise most excluded. I think one of the great things about subjective ways of looking at well-being is that everybody has a weight in it, and they have a weight of 1. And then you can look at the individual groups, and you can find out those groups which have the lowest levels of well-being, and concentrate your policies and resources on those. So in that sense, you give them a higher weight.
Is that through a political judgment? Through a political
yes,
judgment?
Exactly. That becomes a political judgment, because I think when all of us look at well-being numbers, you know, there are 2 things you could do to get average well-being up. One is you could take those who are happy and make them blissfully happy. Those who are miserable, make them less miserable. And I think all of us would say, well, actually converting happy people to really blissfully happy, not sure what, you know, is that really worthwhile? And I would say, let's concentrate on the bottom end. That's fairly straightforward. And that's the kind of area where governments are needed. To be honest, taking people to their bliss point is not really what I'm about. On your second bit about replacing GDP with wellbeing, no, I wouldn't. I certainly wouldn't replace GDP. We've had it for a very long time. It's incredibly useful for all sorts of things as a measure of activity. As long as you know what you're doing with it, it's useful for macroeconomic reasons and all the rest of it. It's one of the reasons why, going back to your first question about David Cameron and the like, the important part about starting the wellbeing measurement back then was you can't really, you know, with GDP, just if when you start doing GDP, you don't really know what to do with it, because you've got to see it through a cycle. You've got to see how it changes, and you then need the data so you can analyze, well, what are the determinants of it? What makes it shift? It's what macro policy is all about, really. You know, fiscal and monetary, you know, what's their implications on GDP? So with well-being, we need to get to observe it through cycles and through big changes. And boy, you couldn't have asked for bigger changes than we've seen through the COVID period, because that's these series which average levels of life satisfaction in England around 7, but they've moved dramatically during this period. So we've seen, and we're able to pick out and learn about what really matters a lot. So it has, in that sense, been an incredibly useful experiment, but obviously not one would have wanted to have.
Well, in as much as we hope that it will lead to policy innovation and therefore a better future, then hopefully it won't have been entirely a negative experience. Thank you, Lord Gus O'Donnell, for joining us today. We've been really enjoyed the conversation, and we're really appreciative, given you've just come back from a long trip, that you've joined us here today. So thank you.
Not at all. Thank you very much. I'm sorry I just couldn't be with you in person.
I don't know if you heard that, but there is. Thanks, Gus.
Great.
Take care.
Thank you. All the best. Bye.
Bye now. Fantastic. We would have loved that to be in person, so especially to those in the room, apologies that it wasn't quite as interactive as we'd like, but we were delighted that Gus was able to join us. So I'm going to hand over now to our next panel, which is on what needs to happen on workforce. We're going to have a chair from HSA, Annabelle Collins, and an amazing panel that she will introduce. And we will then have a chance for everyone to have tea and chat over a break before we get into the second meeting.
I'm sure you use the laptop and the secure to make people when you do that. It's like that you would say everything. How do you design it? Yeah. Okay, so sorry. Sure. How many students today in this meeting?
Yeah.
Just waiting on one. It's fine, yeah. Two 40 to 320 is the time.
So if we start to chill,
Okay.
No
No worries. Yeah, that's mine. So
No, just about
it. Okay, we're just waiting for our final panelists, but I think we'll make a start. So hello and welcome to this panel. We're going to be talking about what needs to happen to workforce. I'm your chair. My name is Annabelle Collins. I'm a senior correspondent at the Health Service Journal. And I'm really pleased to be joined by a great panel today, representing quite a few different members of the health and care workforce. And we'll be discussing the immediate issues facing the workforce, as well as kind of taking a more long-term view of what needs to be done to solve some of these problems. So I'm going to first of all introduce my panel, and then I'm going to ask them to speak for a few minutes before we move on to questions in the usual format. So I was going to start with Professor Jane David, but she's not here quite yet. So I think in that case, I'm going to turn to my right and introduce Dr. Tom Gardner. You're an NHS doctor and also a member of the IPPR Workforce Assembly. And then Sean, to my left, Sean O'Sullivan, Head of Policy at the Royal College of Midwives. And at the end, Lara Pomona. Lara is Associate Director at the Royal College of Nurses. And then we'll soon be joined by Professor Dame Jane Dacre, who's a former president of the RCP and professor of medical education at UCL, and also a recent chair of an independent review into gender pay gaps in medicine in England. I think first of all, I'm going to, if it's okay with you, ask Tom to kick things off, just to speak the first 5 minutes.
Yeah, of course. Thanks, Annabelle. Thanks, Chris. So I'm going to talk about staff burnout because it's something we hear about all the time in the news and on Twitter. And the reason I wanted to talk about this in my 5 minutes is because it's not just stress, and I want to explore that a little bit more. So I'm going to start off with the World Health Organization of workplace burnout, and they define it as a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed. It is characterized by 3 dimensions. Firstly, feelings of energy depletion or exhaustion. Second, feelings of negativism or cynicism related to one's job. And thirdly, reduced professional efficacy. So we know that before the pandemic, around a third of doctors described themselves as feeling burnt out, and that was from the BMJ. And post first wave, 92% of trusts told NHS providers that they had concerns regarding staff wellbeing and burnout for obvious reasons. I think it's probably worth noting here as well, though, that we don't have any data on social care or any good data on social care workforce burnout, and that is a gaping hole in our staff wellbeing data arsenal. So let's take each of those domains in hand. So the first, feelings of energy depletion and exhaustion. Well, for me, this comes down to a supply and a demand issue, very basically. The demand one is obvious. We've had the pandemic. But now we have the very real prospects of an Omicron wave leading to rises in hospitalizations and deaths, whilst also trying to manage elective recovery that has got significantly worse, or the backlog has increased significantly during the pandemic. Worth noting here, particularly the impact this is having on primary care, because they're having to do a lot of the looking after patients who are waiting for an operation, and that is not easy. And then supply, I'm sure we're going to come onto this in more detail, but workforce shortages in both the healthcare and social care sector are clearly very severe, and they're not looking like they're going to get better anytime soon. So I think that issue of supply and demand are the perfect storm to lead to these feelings of energy depletion and exhaustion, because the workload is so high and there aren't enough people to do it. The second, feelings of negativism or cynicism related to one's job. So I think this is where we start to deviate slightly away from just stress as one of the causes of burnout. And for me, moral injury and moral distress experienced by healthcare workers during the pandemic is a key driver of this. So if I think back to when I was working on a respiratory ward for 8 months of the pandemic and how that work differed to pre-pandemic work, clearly at the time, at the beginning of the pandemic, we didn't really have any treatments for COVID at all. So there was a big feeling of helplessness that we couldn't really do anything for these patients. And we didn't have any control over what was leading them to come into hospital. But also the number of deaths, and I know it's obvious, but the number of deaths was working there on the ground markedly different to normal. So there was one night shift where I think I went certified 8 deaths, and normally it would be none or 1 on an average on-call shift. So that was very significant, that moral distress, and I think that has led to just general negative feelings surrounding what we can do as healthcare workers. And also noting here that the Health and Social Care Select Committee in their report on staff burnout made a really important point that discretionary effort is the rocket fuel that powers the NHS, but it's not sustainable. And basically what they're saying there is that lots of people work over contracted hours because they love their job and because they know the job needs to get done. But that, particularly post-pandemic, is not a sustainable way to carry on. And I was at dinner the other day and my friend asked me if doctors got bonuses. Genuinely, he actually asked me that. And I went away thinking, it was a real crisis of consciousness. I was like, conscience, have we really not cut through this issue of workplace burnout? But then I think we probably have, and it was probably just that he was a banker that he asked me that. But it's just the perception of that. And actually, we don't get bonuses, but what we do, so my partner has paid £2,500 this year on exams that he needs to do to become a registrar and consultant, for his GMC license, and for a portfolio that is used to track core competencies. So rather than being a bonus, it's almost the exact opposite. And then finally, that third dimension of burnout, reduced professional efficacy. Well, I think this one goes without saying that if you have a burnt out workforce, you are going to have increased absenteeism in your workforce. But even then, when staff are in, the impact on patient care and patient safety is going to be significant as well. So across the board, burnout is more than stress. And I'm sure we're going to use that word a lot today, which is why I wanted to use my 5 minutes just to unpick it in a little bit more detail.
Thank you so much. So many things to bring up later in the session. And welcome to Jane.
My apologies, under credit to the Northern Line.
Blame everything on the Northern Line.
Blame everything on the Northern Line.
I think maybe we'll go to Shaw next, just as you've just got here, just to
Yeah, I don't mind.
Are you sure?
Yeah, I don't mind.
Okay, all right, in that case, yeah, right. Jane, why don't you?
So good afternoon. I'm really interested just listening about burnout, actually, because that is a really big deal. So what I want to talk about is workforce in general, and then women in particular. And so what I would like to say is there's a lack of a suitable and suitably trained workforce is actually the biggest barrier to achieving excellence and to getting the NHS back on its feet after COVID. And now I have some reason for saying that is an evidence-based statement. It's not just a perspective. And one of the things that has become very clear is that workforce planning is an inexact science. And I don't know whether any of you remember, just, it doesn't have to be too long, just over the last couple of weeks, the Jeremy Hunt amendment to the health bill that was whipped against and was lost. And in fact, there's a couple of questions today where it's been supported in the House of Lords by Lord Stevens, and Naren Patel, Lord Patel. So the problem with workforce is that we get the workforce that the country thinks we can afford. We don't get the workforce that the NHS needs. And assessments of workforce suggest that the NHS is very significantly understaffed to be able to deliver the care that it gives. And if I go back to, I'm a consultant physician, if I look back at my own college when I was president of the college, and you look to the north of England, and in the north of England, 40% of new consultant posts that were advertised, where the trust decided to prioritise their spending on those posts, 40% of those posts were not filled because of lack of suitable applicants. And the College of Physicians has suggested that we need to double the number of medical school places in this country to do that. Now, the other thing is that the gaps are not just caused by lack of appointments, the gaps are caused by burnout, and the gaps are caused by people leaving. And people leave either because they're burnt out, or they leave because of their pension. So there's a massive punitive pension tax, which is hitting consultants earlier and earlier, and they're leaving because it's costing them money to work. If I move on to women, women make up 77% of the NHS workforce and rising. Some estimates say it's 80% of the NHS workforce. It's half or more than half of the medical workforce, depending on which specialty, and women make up more than half of the specialties. But there is a gender pay gap. So a gender pay gap is defined as the average hourly earnings of women as a percentage of men's salaries. And in medicine, I'm only talking about medicine now, the overall gap is 16.8%. So there's a very significant difference in the amount of overall pay that women are taking home compared to men. It's not It's slightly more complicated than equal pay, because the gender pay gap varies according to a number of things, and the pay gap is so large because the men in the medical workforce tend to be older, tend to be in more niche specialties, and because they're in senior, higher paid roles, they exacerbate the gap. So the men are benefiting from a traditional career trajectory that was set up in the 1950s, where the workforce was male. You went to work every day, you got an increment every year. We have long spine points, and gradually that pay gap increases because the women dip in and out of the workforce when they have caring responsibilities. The other thing is, we talked about bonuses. Consultants get clinical excellence awards, which are thought to be bonuses. Those bonuses are more likely to be awarded to men than they are to women, and extra payments for work are more likely to be given to men rather than women, and there are all sorts of reasons for that, and I'm not going to blame anybody there, but that is a fact. The Gender Pay Gap Review was the biggest review of its kind, looking at these differences between men and women, and we're lucky to have the NHS to be able to get such incredible data sets, huge data sets, and supplemented by survey responses and in-depth interviews. And we came up with 7 themes and 42 specific and pragmatic recommendations, and yeah, if you've got the rest of the afternoon, I'll go through all of them, but actually no, we haven't. So edited highlights here. Senior jobs need to be made much more accessible to all groups, to men and women and people from different backgrounds. The system barriers that I talked about men plodding through the workforce, getting increments, need to be addressed and harnessed so that women are more likely to progress. So if your progression stalls when you're on a period of out of work, it needs to be able to get back on track quickly. At the moment, it takes about 15 years after a period of maternity leave. It's called the motherhood penalty. We need to increase transparency about how much individuals are paid. We need to make some of these changes mandatory rather than just suggesting it would be good practice to have men and women on shortlists, for example. We need to stamp out inappropriate behavioural put-downs of people from minority groups. So we need behavioural and cultural change. We need to look at how clinical excellence awards are made up and how they're given to people. And we also need to do regular research with monitoring so that those pay gaps are looked at on an annual or similar basis, so that we can see whether they're getting bigger or smaller, because it looks as if COVID has made them get bigger. That's me.
Thank you very much. And now I'm going to hand over to Sean.
Thank you. Good afternoon. First of all, I want to say what a pleasure it is to actually be in the hall, giving a talk in person, but also on behalf of the Royal College of Midwives, how pleased we are to be working with IPPR, and we've, I think, developed a good relationship over the last 18 months. So I'm going to focus on the midwifery workforce and what we see as the continuing and worsening staffing situation, say a bit about how we've got to this situation, and then maybe suggest some measures, both short-term and long-term, to alleviate that. And I think this will probably resonate across other staffing groups because we're seeing such severe shortages across the board. So in midwifery, our assessment, based on the number of births last year and using the Birth Rate Plus workforce planning tool, and we're fortunate in maternity in that we actually have got a credible workforce planning tool, but this suggested to us that at the beginning of this year we were short by about 2,000 midwives. Unfortunately, since then, we've seen month by month over the last 6 months a fall in the number of midwives. So if anything, the situation is likely to be worse still. And bearing in mind that in March this year, NHS England announced £96 million worth of funding for midwifery recruitment, and that Health Education England has also reaffirmed a commitment to training an extra 3,500 student midwives in the 4 years to 2022. So things could be even worse still. It's becoming ever more apparent then that with these shortages, maternity services are really creaking under the weight of increasing demand and unceasing pressures and the impact this is having on both midwife numbers and on the morale of staff. So it's really no surprise then that we're seeing a growing number of maternity services being receiving poor CQC ratings, or that nearly 60% of our members have said that they have been thinking about leaving the NHS into next year, or that last month we saw a series of vigils around the country in support of midwives. So as to why we've got to this point, I don't think it's any great mystery. There's been years of underinvestment in maternity services, the absence of proper workforce recruitment and retention strategies, patchy and inconsistent adherence to safe staffing guidelines. They've all contributed. And then on top of that, obviously working through the pandemic, and for maternity services, also trying to implement a major transformation change program. So taking all that together, it's little really wonder really that staff numbers and morale are nosediving. And the recent drop in the number of midwives may be an indication that whereas last year some midwives made the decision to defer retiring or stay in the workforce out of a sense of duty to their colleagues at a time of great crisis. What we're seeing now is I think they're deciding that they can't put off decisions to leave any longer. So what are the solutions? Well, we're working with NHS England and Health Education England on looking at increasing entry routes into midwifery, and there are ways you can do this through return to practice, overseas recruitment, bringing in shortened courses for nurses who might want to move into midwifery, although we're conscious that nursing has its own shortages, so there's a danger of robbing Peter to pay Paul. And in any case, these are only likely, we think, to generate marginal improvements in numbers at best, and actually focuses on recruitment when the real problem is retention. How do you stem the flow of our members leaving the profession? So there are other things that we would like to see happening, and there are things that can be done in the short term to address retention. You could use recruitment and retention premium, particularly to target posts in areas with the greatest shortages. And this is something that in the IPPR's report last year, Care Fit for Carers, about prioritising the health and well-being of maternity staff, for example, by retaining some of the measures that were brought in during the pandemic. So safe rooms, access to psychological support, also things like free car parking and access to hot meals. There are also, I think, some quick and practical things you can do to get newly qualified midwives into the workforce quicker. So we're talking to the Nursing Midwifery Council about, for example, trying to get PIN numbers issued more quickly. More significantly, I think, there are things you need to do about ensuring that where you are implementing major change programs, such as continuity of carer, that you're only doing that when you're assured that there are safe staffing levels in the service. And above all else, then there's promoting more flexible working arrangements so that midwives have greater choice of control over where they work and what hours they work. But we also need to look at more solutions in the medium to long term, because just as the situation we've got into has taken years to sort of bring about, so you can't suddenly magic up 1,000 midwives at the flick of a switch. One of the lessons I think from the pandemic was going back to the early stages, the way that actually organisations like ourselves, NHS employers and government ministers actually work together to bring about solutions. And we saw ministers speaking to unions in a way they hadn't done for going back 10 years or more. We need to see concerted effort across government, employers and staff organisations around the sort of things that actually Lord O'Donnell was talking about well-being at work. So increasing opportunities to work flexibly, tackling issues such as discrimination and bullying and harassment that create toxic workplace cultures, promoting more multidisciplinary working and learning, and developing pay and reward packages that not only incentivise retention, but send out a message that staff are truly valued. I think I'll finish on that note.
Thank you very much. And now over to Laura.
I echo you, Sean, about how nice it is to be in a room with actual people. I think this is the first time I've actually publicly spoken in 20 months. So I represent the Royal College of Nursing, which is 500,000, almost just under 500,000 nurses and nursing support workers. And I started my public policy career 20 years ago, actually, in nursing, and I just circled back around at a really special time. And loads of things have changed, but some things haven't changed at all. And I think the incredible dynamism and expertise of nursing has never been more visible in people's lives in a very passionate way. And I am personally a professional advocate for universal healthcare, so I'm a firm believer, of course, that until we solve the nursing and the lack of available nurses within any health system, we will never have a chance of achieving that. And I am Associate Director of Policy at the RCN, where I'm accountable for England's activity, UK-wide work, and international facing work. But I am here today to talk on the England context in particular. And I think while I'll speak a bit about nursing, you'll hear some examples in there, I would like to make some assertions around how we solve the workforce crisis, quote unquote, in the long-term sense on behalf of a range of professionals, because I think some of the things I'm going to say have direct applicability for a lot of groups. So obviously we've heard about the lack of supply of the workforce, the lack of what's known as safe staffing. We've mentioned moral injury, terms and conditions not being good enough hasn't really been discussed, but we've kind of edged into the need for professional development and support. I don't think I need to floor you with statistics about all the things that are going wrong, because I think it's probably visible enough what isn't working, both in health and social care and public health. Let's not forget all three of these, and the supply for many professionals comes usually through the same route, and then they end up working in different care settings. So I think there are four things at the top of my mind when I think about how do we fix this situation. And the first is, of course, retention measures. And that's applicable for any employer, not just the NHS. Politicians have a habit of asking, what are the things I can do right now to fix this? And I am going to focus in the latter part of my comments about the long-term solution, which I do believe is legislative, because the bill that we're facing right now is literally the greatest opportunity we've had in quite a long time. But the second thing we need is credible and commensurate pay terms and conditions. We definitely need that across healthcare settings. And we do need accountability for supply of the workforce in each country of the UK, and that needs to be set in a global context. So these issues that we have are not unique to the UK, and let us not be small-minded and think that they are exclusive to us. And there is a very prescient risk of an over-reliance on international recruitment, despite the value of our international colleagues. And a very terrible kind of scenario where we're talking about vaccine equity in low-income countries while also seeking perhaps to poach workforce professionals out there who are desperately needed to deliver those vaccines that we're overdue giving. The fourth thing is definitely around conversion of public support to political action. I think the public generally understands how serious the situation is, but that hasn't yet turned. That whole thing about standing on our doorsteps and clapping, but not actually being able to guarantee political decisions. And everyone out there is exhausted. Every member that we speak to is absolutely exhausted, and yet there has never been a more important time for the voice of the health and care workforce to be heard and for it to be responded to. So I'm not going to argue all the points about why workforce measures need to be addressed in the current legislation. I'm going to tell you about two specific parts, because I thought if there was one thing I could do, it would be that we would walk away with a crystal clear understanding of the two most important measures that are missing from the existing health and care bill. So the first, Jane has mentioned with regards to the amendment that Jeremy Hunt tried to put through in the House of Commons. There are essentially two strands to solving this problem in a fundamental way. The first is around the fact that we simply don't have transparent data that is sufficient for purpose around what on earth we actually need. When you hear about vacancy rates often in the media, what you're hearing is about the number of funded posts that exist that we can't put bodies into. That gives no credence whatsoever to the actual workforce shortage. So I'm very careful when I talk about this issue. Vacancies are not the same as shortages. We don't know what the shortage is. The truth is we don't have credible projections of either what the services need, health and care, or indeed what the population needs. And that is what's known as Hunt's Amendment now, which is actually represented by a very large army of organizations who are stating unequivocally that this legislation has got to be amended so that there is a duty to assess what that need actually is and to transparently and publicly make that available. That, of course, is not a measure that's going to be supported possibly by the government. They'll probably battle it all the way through, because of course, once that picture is available, it then becomes a political accountability question as to what on earth are you going to do about it, now that we all know how big the hole is. So the second part, which the Royal College of Nursing
appears to be a little bit alone on, but we're going to keep pressing on. So an amendment was put forward in the House of Commons by Justin Matters, who's been reshuffled in the last couple of days, as you may have seen, around securing accountability for the supply of workforce and a demand-led workforce strategy to live with the Secretary of State for Health and Social Care. Now, some people would argue that the existing legal duties to provide a comprehensive service, which is the existing duty around the Secretary of State, are sufficient for purpose, but we have seen successive governments who have not dealt with this issue. So we believe fundamentally that accountability is the second strand. And without these two things, we don't have much of a shot. And so I think if I could leave you with one parting thought, while it might feel like late night dull bedtime reading to you, the Hansard transcript from the House of Lords debate yesterday and what is coming through is fundamentally important for you to read. While the House of Commons may have passed over these measures and rejected them, Lords are offering proper scrutiny, and you'll see a very interesting exchange between Lord Stevens and Lord Lansley, the architect of the last bit of legislation and the architect of what is coming before us now, as well as what is very important to me and to my members, cross-party political support for action on these workforce measures within the bill. So we are in a situation where there's a very real possibility we could make it work, but it's going to require a lot of voices which I'm sure are shared by my colleagues on the table here. So I think I'll stop there.
Thank you very much. Okay, soon I'm going to hand over questions, but I would just like to take the chair's prerogative and ask a first question about workforce planning. So just picking up on a few of the points you mentioned there, really, Lara. So Health Education England is currently doing a major piece of work looking at medium and long-term workforce supply and demand. And I just wanted to ask the panel whether you've been engaged in this work, perhaps whether you feel optimistic that this can go some way into shedding more light on shortages and perhaps producing a kind of a stronger workforce plan for the health and care sectors.
The RCM has been involved, and we would feel more optimistic about the outcome were it not for the announcement that Health Education England is going to be merged with NHS England. And from our point of view, that is a concern. Our experience is that health education has a greater level of expertise around workforce planning, and certainly we've been able to come to more of an agreement with them on the extent of shortages in midwifery than we have with NHS England. So that to us is a bit of a red flag.
Okay. Any other comments, Lauren?
So I completely share that view. It is very clear that there are workforce shortages across the board, and Health Education England had a rocky start after the 2012 bill, and were finally beginning to get a much better understanding of workforce. The trouble was they were more told what to do than asked what their advice was. And the problems recently, I understand, were stemmed from them being denied the funding that they had requested in the autumn statement. And so they are sort of backed into a corner, because the only way that they can have access to more money is by merging with NHS England. But the reason why they were set up separately in the first place was because NHS England, well, it didn't exist then, but because the NHS used to take the biggest slice of the pie, and workforce and education were always an afterthought, and so thought it needed to be ring-fenced. So although completely see the rationale for doing that, I think it's actually quite worrying.
Oh, I think I'd just add that, you know, I have some very well-respected colleagues at HEE who, with all the best will and intention in the world, you know, we have to be honest, the agency doesn't have not only the funding, but the levers to generate the supply of workforce. They legally just can't do it. So it needs, this is why I'm just going to come back to the law point. And while I think I'm like law code, at its worst, law can codify intention, right? And say we should do this stuff, such as pay genders equally. And at its best, law can transform and change systems in people's lives. And so that's why I'm always going to keep hammering this point. HEE could, even in its merged function, do more. But at the end of the day, it is still a government accountability question about whether or not the services, including those you pay for through your taxes, should be staffed for safe and effective services. And until HEE has more muscle, as it were, and some legal levers there above it, I just don't think anything can change. And the strategic framework piece is going to be very useful, but what it's going to do is set the scene for the requirement for a workforce strategy. It's not going to be the piece itself. And it certainly isn't going to magically produce the workers that we need to staff our services. Yeah.
Okay, I'm now going to open it up to the floor. So if you do have a question, please wave your hand. Lady at the front there, just wait for the roving mic, if you would.
We recognise that retention is one of our major problems. How do we work to address the reduced funding for prevention to education in enabling all workforce and enabling retention across the
Absolutely. Who would like to answer a question on retention?
It's so hard to do anything without funding, let's be honest. And I know, I mean, Matthew said it very eloquently earlier, when you're an advocacy organization, you're in the business of always going, not enough, give me more, but that is the fundamental truth. I can think of a really practical example, but unfortunately, it comes back to the Sisyphean issue of workforce gaps. You know, one of the most basic things that our members talk about is not being able even to have time to take breaks or go to the bathroom or drink water, which seems completely inconceivable for those of us who don't do shift work. They also don't have time and support to do mandatory training to keep up with their basic professional qualifications. So I would say at the minimum, the most minimal basic retention measure you can do is to start to carve out space to treat people like human beings, and not you specifically, but I mean just generally, and also to make sure that they're able to keep up they're able to keep up their professional practice in line with the code that they've signed up, you know, and they're committed to delivering to. I think those are the two most basic things I can think of.
And I just add that in terms of, particularly on the point of continuing professional development, the only CPD that, you know, I don't want resilience training to be the only CPD training that I'm doing, but it tends to be one of the more mandated responses to the current burnout crisis within the workforce. And, you know, I get that sometimes you do need to try and treat the symptoms, and I'm not saying these things should be abolished, but the trouble is that they're not forming part of a wider retention package, which I agree does need to include really basic things like letting people go on conferences that they really want to go to, maybe seeing if we can find some money to pay for that within study budgets, and have places to actually, you know, there are places where nurses and midwives can go and socialise in hospital, but also literally the places to go and spend this time, doctors' messes, are incredibly variable throughout the country in terms of A, their existence, or B, the extent to which they're actually kept free of rats and cockroaches, etc. So,
or lockers.
Or lockers,
yeah, so it's quite basic, I think, some things that people.
Absolutely. I can see another question. The lady in blue.
Hi, thanks. It's more of just a comment related to that point. So I'm a doctor. I was working in the hospital up till March, and then I also spent a year working in health policy, which is just really eye-opening for me. So I think a lot of people that haven't worked in the NHS don't actually realise the disrespect that workers are treated with. Like I recall in the last hospital I worked in our kitchen on the ward, where they had teas and coffees, there was a big sign up saying if workers help themselves to teas and coffee, they'll be fined. At the end of last year, they actually put up a camera in the kitchen to see if staff were going to go in to catch staff like using the tea and coffee. And I remember that when I worked outside the NHS for different jobs, and just tea, coffee, bread, all these sort of basic things being the norm. And I think we've just got to this point where there's such a bad culture within hospitals, which I think a lot of people that don't work in hospitals don't see. So it's not a question, but it's more of a comment, sort of basics like tea and stuff that's not being done. So sorry, I just got being with them.
That's fine. just for the benefit of people watching virtually, that was just I don't think people can hear virtually, but that was just a comment from a former NHS doctor.
No, I still am.
You still are?
So
Okay.
but just basics, like doctor's mess. Like when I was doing doctors, I was mess president. So doctor's mess is the I guess the staff of the doctors. We raised money, so we have to pay for my doctor's mess. We raised lots of money, we wanted to get some new sofas and things for the doctor's mess. And then I wasn't allowed to get a sofa bed because apparently doctors are not allowed to lie down, so we're only allowed to take chairs. You know, it's a culture problem, an attitude, how they treat workers, which means sometimes submits people that don't wear NHS.
Okay, now people can hear you online apparently, so that's good news. So Sean, sorry.
Well, just to say, I think it's absolutely mind-boggling some of the things you see going on. I mean, we've had midwives in one trust in London, 60 of them were being threatened with take to court because of where they're parking their cars, and when they reintroduced charging for staff, There was something I read in a paper a couple of days ago, a final year student. Now, if you think about lockdown and the contribution that final year students made coming into the service, she was told, actually, you can all go and eat in the main canteen. You're not allowed to come into the staff common room. I mean, for heaven's sake, it's the way people are treated sometimes. No wonder people are leaving.
So just to sort of try and play the elder statesman though, one of the things about the NHS is that it is an extraordinary service, and there's nothing better to do in life than to care for people who are sick. And so all of the staff that work in the health service have this fundamental sharing of core values about caring for patients. So it would be unfair if the impression was given that everybody just whinges about whether they can eat in the right canteen, because these are a set of people with a really strong moral code for looking after each other and looking after colleagues. And the trick is to find a way to value, support and motivate this extraordinarily committed workforce with, I think, more than 1.5, there are 1 million women working in it, and more than 1.5 million people working in it. And so there's something about the culture that we need to turn around to make people feel proud of what they're doing, rather than worried about all of these little microaggressions that come out from an organisational distress.
Perhaps, Tom, this might be one for you, but maybe some of the things that more positive things we've seen that have been introduced during the pandemic that kind of made a difference, reduce burnout, improve retention, perhaps.
Yeah, absolutely. I think we've seen those examples occurring at both the system level in terms of collaborative and transformative projects that have happened because of COVID that probably never would have happened otherwise. And a lot of those have been about staff welfare. I think actually communication. So we saw during the pandemic that both at a national level, but also at a trust level, how communication and the management of hospital changed from kind of going towards a little bit more of a command and control approach. But actually what I noticed was that communication with staff was actually, I was lucky at my hospital, really good. And there were lots of forums at an increased level compared to pre-pandemic to talk about these things to do with welfare. Lots of little things in terms of wards having, they called them like wow boards to like promote positivity, because Jane's right, everyone, there's a reason why these people are in their job, and there's a reason why this discretionary work is a big part of our jobs. We do it because we love it. We've gone into it because we know we're not going to be paid as much as our peers who are doing much more lucrative careers in terms of how much they're earning and where they live. But we cannot take that for granted. And if we don't get those basics right, then that's where we're going to see that discretionary element to this starting to fall down. But yeah, there have been loads of positive things to welfare, and it's important to remember. Exactly.
So I just wanted to take a question actually from our online audience. So this question is from Jane Simpson, and she's asking, what do we need to do to create parity between NHS staff and the social care workforce, and how can we end the stereotype of social care staff being an unskilled workforce? And this is something we touched on a bit earlier, but I think it's really important. So who would like to tackle that one first? Sean.
Only really to say that there are real risks with the disparity in terms of actually, for all we moan about NHS paying conditions, actually they can look relatively attractive if you're working in social care. So one of the dangers of not addressing that is, for example, I could imagine some social care staff looking at, say, maternity support workers and thinking, actually, you know what, why am I doing this when I could be doing something equally valuable and actually the terms and conditions are better? So I don't think it's in anyone's interest, well, there's such a sort of chasm between NHS paying conditions and those in social care.
Any other comments?
I can only echo that. I mean, at the end of the day, whether or not we like it, we live in a capitalist structure which values sort of our contributions through remuneration. So it sends a very clear message when professionals who work in care settings out with the NHS are not paid anywhere near the same as their colleagues. So I think that would go quite a long way, actually, towards addressing both the recruitment and the retention issue in those settings.
And I would just add that this isn't a solution, but in order to come up with the best solutions, we need data to properly understand the problem. I think we can assume that burnout is going to be a big problem in the social care workforce, but there is no equivalent of the NHS staff survey for social care. And I think we need to have a little bit of a think about how we address that. It's going to be harder because it's fragmented, but it's important to remember the data as well.
Just a question. I mean, I'm from the Royal College of Physicians. We've got the Royal College of Midwives. We've got the Royal College of Nursing. Where's the Royal College for Social Care? But they're not as well represented either. They're not as well represented they're not represented on this panel, for example. So the representation of social care and encouraging social care to become better represented would I think help to get their voice across, because it badly needs to be heard.
I want to ask anyone else in the audience if you'd like to ask a question. Yes, just wait for the mic if you wouldn't mind. Thank you.
I'm from Central Organisation. A question, we talked about shortages, not just vacancies, which are gender pay gap, social care. As Laura said, you can't do anything much without money. How much do we need to put into the workforce side of things? Is it multiple choice terms, 10%, 50%, 100%? What sort of order of magnitude are we looking at here?
So just for listeners online, that was a question about how much do we need to invest in the workforce? Who wants to go?
I'm going to say something highly political. I think that depends entirely on what we think health and care services should be providing to the population. So until we set some boundaries around what kind of services people expect, I don't think you can make a determination about how significant that workforce should be. And it is the billion-dollar question, right? But at the end of the day, there are big political conversations to have about what taxpayers think they can and should fund. And certainly we're seeing that conversation in social care already with what this administration is putting through. So I think we have to answer that question first, and then we can talk about how many people we need and what kind of skills we need to deliver that. That would be my starting point.
Well, I'll give you a quick answer on midwifery. So, for example, NHS providers in their evidence to the Health Committee's inquiry into maternity safety said that to bring midwifery recruitment in line with Birth Plus recommendations will be in the region of 250 to 350 million pounds a year. So that's just one specialty. So, you know, we are talking billions, but I think it comes back to the point that Jane was making earlier, that currently workforce planning systems are based on what's affordable, not on what patients and service users need for safe and high quality services. And until you are able to bring that in, then you know, it's about short-termism.
I think there's also an issue that you can talk about midwives, I can talk about medical students and doctors, you can talk about nurses, but we're not looking at the whole of the workforce. And so we tend to have each individual sector coming up with their own data and looking at their own solution. Until we have a solution that's applicable across the whole of the NHS, it's almost impossible to say without just sort of saying, well, I think we need, and if you do that, it can be easily undermined because all the data sources that people use are different.
Could I just add on that as well? And one real missed opportunity, and you know, everyone remembers the Francis report and all the recommendations, and yet again, these will be implemented. We don't want to go back and have another report. Well, one of them was on safe staffing. There was meant to be a safe staffing program, and I think there are initially going to be 10 staffing groups that kind of looked at. After the second safe staffing program, which was midwifery, and we're grateful we got that in, that was suspended and it's never come back. And A, that was a real missed opportunity, and B, you know, again, you get something like France, which everyone says never again, and you know, after a matter of years, all the recommendations get rolled back.
Any final comments before I wrap up? About 1 minute left.
Just that work on staffing was killed, staffing guidance was killed because of the cost implications. That's what happened.
Yeah.
So it does come down again to what do we expect and need from our services, and how should the government fund them or ask us to fund them in contribution. It all comes full circle, really.
Thank you very much. And unfortunately, we've run out of time, so I'm going to need to draw this panel to a close. But thank you all so much for joining me. I had loads of questions to ask. It was really interesting. And now I'm going to hand back over to Chris and a tea break. So thanks.
We are going to have a quick break. So back in 10 minutes, there's a team looking back. We've got a really exciting afternoon tonight, so do stick around. We've got a panel on how we build that better in the NHS and what the reform plan looks like, and also a panel on social care, which is pretty topical. And we will wrap up this evening with wine, so there's reason to stick around for the alcohol. And more excitingly, an exclusive screening of Limbo with award nominated process of the So enjoy the tea coffee and we'll see you in about 20 minutes.
Hi everyone. I'm Parth, I'm a fellow here at IPPR and a clinical fellow at UCL. And we have a panel now on what on earth building back better means for the NHS. What could it mean? What should it mean? To borrow a phrase from Matthew earlier, let's think about what an ambitious but realistic building back better might mean for the NHS. Got a great panel here with me today to start talking about that. They've got a wonderful 5 minutes each to deal with this question, and then we'll open it up for about 15 minutes of questions from the floor and our audience online. So I'll say a couple of lines just to sort of texture the conversation, and then I'll introduce my speakers. So it's going to be easy to forget, but the NHS was facing somewhat of an existential challenge before the pandemic, which was the whole idea behind the long-term plan and quite radical reform plan that came with it, the integrated care systems being sort of the pinnacle of that. And that was essentially our universal health coverage system dealing with the challenges of epidemiology and demography. And then within that context, the pandemic landed, which is really identified all the pressure points within the NHS and pressed the red button. Most visibly seen now in the median waiting time for an ambulance to get to if you think you're having a heart attack or a stroke. It's about an hour for any clinicians here. You know how ridiculous that is. So if that's not really a health system under collapse, what is? And well, in there, from that point, what does building back better look like? So that's what we'll talk about today. What can we sort of feasibly try and achieve, and how far are we away from that point? With me in no particular order, I have Penny Dash at the end, who has a long career in strategic thinking in the healthcare world and is currently the chair of the North West London Integrated Care System. Next to Penny is Ben, who is the managing director of Carnal Farah, a healthcare consultancy that works both on thought leadership and on data analytics. And we work very closely with Ben and his team here at IPPR. Next to me is Mark Cooley, who is director of Imperial Healthcare Partnerships, which brings together different people involved in the provision of health and care in London, and is doing some really exciting work in improving the quality of care that people receive. And last but not least is probably the country's most esteemed health economist, Anita Charlesworth, who is director of research at the Health Foundation. Why don't we go in that order? Penny, let's start with you, if that's okay.
Okay, very good. So I was going to share a few thoughts. I very much share where Amanda Pritchard's chief exec is, i.e. things are very challenging at the moment, but equally there is plenty of opportunity out there to move the health and care system forward. And so certainly plenty of room for optimism. I think the principles of the long-term plan, which you referred to, remain. However, I would suggest that the long-term plan is perhaps not the clearest strategic document. It includes 426 deliverables, which I would tell you is probably rather hard to get your head around. So what we're doing in North West London is to try and create perhaps a slightly simpler framework for how we think about the future or building back better, which is essentially around 9 areas. So I'll just give you highlights of that, as we don't have much time. So the first, and probably most important by a long way, is population health. So really trying to get to grips with the public health agenda. I was a public health doctor quite a long time ago, 30 years ago. I think some things have gone backwards, definitely. Some things have gone forward, so much better on smoking, far worse on obesity. But the general principles really trying to address the wider sexual determinants of health, really looking at supporting people to live healthier lives, as well as looking at what the NHS itself can do, are all fantastic principles that we need to recognise, and we now need to get on and act. I am, as I think many of you have recognised, slightly disappointed by having conversations and steering groups around rather than actual actions, but hopefully we'll get on to action. So that's the first. The second is out of hospital care. I think most people see the current model of primary care is really struggling big time. We absolutely need to get on and make reform. Many countries around the world that we tend to look at have made those reforms in the last 5 to 10 years. We haven't made them here. So we need to really build on the great bedrock of primary care, but we need to have it look suitable for 2022, 2023, And that requires a very fundamentally different model of care, which certainly many people are increasingly talking about, and hopefully we will start to build on locally. We then need to look at mental health care provision. First of all, how it's embedded in primary care and community care, that real local basis of change. In North West London, we are dividing the health system up into 8, based on the 8 boroughs within North West London. In each borough, we have what we call a borough-based partnership, primary, community, mental health care and social care, working closely with the voluntary sector. And that is where we see the bulk of activity taking place, and that being the most important place for delivering care, as well as specialist mental health care, which we have in the patch. Our fourth area is acute and specialist care. So we have some very specialist services. We need to make sure that they are run efficiently and effectively, and they're not always at the moment. But we also have the bulk of acute care, which again, lots of room for improvement there. We have gone backwards in some of the metrics of elective performance in particular. Our length of stay is slightly all over the place. And we have estates which in many places are not fit for purpose and certainly are not particularly well utilised. So big agenda there around the acute sector. So those are the sort of 4 delivery areas. And then we have 5 enablers, which are workforce. We absolutely have to get to grips with workforce transformation, as well as supporting people in terms of well-being and addressing some of the challenges around attrition. So there have been numerous workforce strategies developed 5, 10, 15 years ago, which look at very different roles, very different ways of working. Very little of that has been implemented. So those strategies remain as valid today as they were back then. We need to get on and implement that transformation. We have fantastic opportunities with data, which we've shown during the COVID epidemic. We want to triple down on that. We will absolutely have a chief information officer, chief data officer within the ICS. And we want to build on all of the great stuff that's been happening over the last year, but also the last 5 to 10 years, and have data at the heart of what we do. Great opportunity for more digital services, all sorts of energy around the country. I've got a call tomorrow with 2 ophthalmologists somewhere in Cornwall who've apparently taken out the whole of outpatients in ophthalmology. So many exciting things happening. We just need to grab them and make them happen and make them stick. Then we talked about estates. I'd add to that finances. We need to get much better at understanding costs. We do not understand costs in the NHS. People don't talk in terms of costs. We aren't looking, need to comment on this. We look at the total amount of healthcare spend in the country versus the number of whole-time equivalents. It probably comes to around £100,000 for whole-time equivalent, which is quite interesting, but certainly not what people are getting in their pay packet. So, where does the money go? What are we spending? What are we spending it on? We've got to get much better at understanding that. And then my final one, which Mark, who works in autism, can pick up on, is there's so much innovation, change, research. We've got Imperials in our pack, we've got Brunel, we've got loads of startup companies, we've got even more private equity groups. How do we harness that spirit of entrepreneurial energy and actually really look at what the future model could look like? So that's what we're doing.
Thanks very much, Penny. Really nice overview there. Ben, we'll come on to you next.
Okay. Do I need to? Yeah. So I'll have many echoes similar to some thoughts of Penny, but I think my starting point is in talking about build back better. It's a very good aspiration, but where we are is struggling to get back to business as usual, and we're let alone to recover, move beyond that, and build back better. So that's where we are right now, and the problem is that we can't just say work harder. The strategy of let's work at 120% sort of indefinitely is really hard because workforce is the constraint and people are knackered. And unfortunately, we're hearing more and more stories about people leaving the service. And so I think the NHS has an absolutely amazing strength in its inspiring mission, which has touched so many, but it needs to work harder at being an irresistible organization and address the things that are causing people to leave in the first instance, and then think about, as Penny alluded to, how can we make greater use of others and draw them into the service and address elements of the workforce that way, because it takes a decade to turn the workforce around. The second thing is that we have, I think the reason that we have this problem of that we have a not back to normal, we haven't caught up the backlog, is because of the model of provision here and a tendency to run the system at close, in the mid-90s of occupancy with elective mixed in with urgent care. And so we have this perennial problem of winter squeezing out elective, and that is, far exacerbated by a pandemic squeezing it out, which creates this problem. I think we need to use this as an opportunity to look at and say, how do we separate out the elective and cancer streams and put the right capacity into the system so that we don't face these sorts of issues. Certainly if you look at what's happened in Germany, they haven't experienced the issues that we have here in the kind of backlog and impact in cancer and other systems. That will need more capacity and more capital, and the scale at which that is moving, the scale and the speed at which that's moving isn't sufficient to the task. So I think what we need to do is look at what we did with the Nightingales and say, if we put our minds to it, we really can do this. The community diagnostic centers are a start, but only a start. We actually need to create more capacity in order to be able to do that. The third thing is to unleash the power of data and digital. The NHS is blessed to have a huge amount of data. Unfortunately, it's locked up in all kinds of different silos and not easy to access or use. And part of that is hidebound perceptions that GDPR is preventing something. In fact, everything you want to do is fully enabled by GDPR. It's just that there's a habit that a data protection officer 5 levels down the organization finds it the safe thing to do, to say, look, can you use this data? And that needs to be changed. Again, we can learn from what's happened in COVID. We had unprecedented flow of data. Nowhere better illustrates that than the vaccination program, which had made use of the master patient index, 62.5 million people fully characterized with names and addresses that were able to invite through the JCBI cohorts to come to vaccinate, and it worked bloody well. So if we can do that for vaccine, why can't we do it for more use? That's data. Digital, we're just scraping the surface on. We made a much vaunted leap to digital in the pandemic, which on closer examination turned out to be reaching for the phone as opposed to digital. And the telephone was invented 150 years ago. So it was good that you could now interact through a telephone, but it shouldn't take 150 years to get to that. Equally, it's not just video conferencing, which takes the same amount of time as doing something in person. There is really transformational stuff. And he's talking about the stuff down in Cornwall. How can we use digital to totally change the pathway and find new ways to support people to be healthy, help diagnose and speed people to treatment, and also support more effective management and productivity of the service. And then finally, I think we need to recognize that the biggest source of innovation has been the life sciences industry. And it's the life sciences industry that's showing us the way out of the pandemic with the diagnostic tests, with the drugs and the vaccine. And if we're honest, the NHS has been deeply ambivalent about the life sciences industry and industry in general, because of the concerns about profit and pharma. But that is going to be the future for us to find ways to better treat and cure diseases. And we need to find a way to embrace the life sciences vision and accelerate innovation in the NHS.
Thanks, Ben. Some really, really interesting thoughts there. Some very timely, the separation of electives and emergency care, I think, over the next couple of weeks. But on that point of innovation, Mark, it's a good time to come in.
Thanks. And I might say something a bit less sophisticated, really, than something too innovative. But I think when we think about building back better and periods in history where it's been as challenging and the ambition has had to be as intensely large, you can go back to the founding principles of the NHS. The Beveridge report coming in 42 was essentially saying, do something revolutionary. And slightly depressingly, it remains prescient, right? 3 major things that Beveridge was saying: by closer coordination, social services, the welfare state will be better, it will be more intelligible, and it will be cheaper. That remains the case. Whilst we can only develop systems by using experience of people who've worked in them, we shouldn't be bound in a path dependency because of sectoral interests. I think that remains also pretty live for us. But there was a call to arms, and I think we've got a similar type of requirement now, which is revolutionary moments in history, Beveridge said, is a time for revolutions. It's not a time for patching. And I think we should set that as the ambition. But in doing so, I think we need to be optimistic about the future. We've heard a lot of things that cause concern, particularly around workforce. We can have some optimism, I think, in the medium term. We've got to have some realism about the starting point. And then I think we've got to have some pragmatism about the next steps. Anita will probably be better placed to talk about the medium term, but I do think there are two major trends, and we've already heard some of this earlier. As economies get more sophisticated and more developed, they tend to want to spend, by preference, more of their productive capacity on health and care services. And that has been a long run trend over time, and I think it will continue. I think that is not an inevitability, but it is a point of preference. And it's never an issue of affordability. It's a point about how economies generate wealth for individuals and the nation. So the health and care sector, is an engine for prosperity if we choose to make it so. I think it's also important, in a sense, safe haven for the labour market. We heard earlier about the existential threats in some sectors that come from automation. Well, if you're a human being and you're searching for a safe haven in the labour market, you need to be thinking about those niches in the value chain that are not going to be substituted out easily. And those tend to be high on relational skills. They tend to be high on problem solving and on creativity. And the health and care sector is abundant in roles that create status around exactly those features. So for those two reasons, I think we can have optimism, but that's only going to be possible if we change. We've heard a lot about the culture in the system. We've got to create a system that people actually want to work in. And I think 3 Ps for me spring to mind. We've heard about purpose, we've heard about pay, and I think we've not heard so much about portfolios, but I don't think the model of working, particularly for clinical professionals, is any longer fit for purpose. There's a sort of an omnivorous desire to work across a range of different things, and I think we need to support that to make this an attractive sector. But it also has to be supported by the public, both as sort of receivers of the service and funders of services. And again, 3 Ps, I think, spring to mind. So there's something about seeing a health and care sector that is professionalised in a specific way, personalised, and also participative. I don't think the public will tolerate professionals running amateur organisations for much longer. And I think that is part of what we face. I think that the public generally want to see personalisation of the service, so some type of differentiation. It's not one size fits all. And in addition to that, I think that we've underplayed the latent capacity for participation. Now that's either in terms of looking after ourselves in terms of self-care, looking after others in terms of volunteering. The pandemic demonstrated a huge latent capacity around that, or actually participating in a political sense in making it easier for local systems to deliberate around some of the hard choices. And we could explore that in more detail later. But we can't have that optimism about the future without some realism about the present. And I think some of the things that we inherited pre-pandemic or have been the long-standing foundation of the NHS are still with us. We still have some of those sectoral boundaries. There's the old adage that sort of GPs got the patients, consultants got the hospitals and the investment, most other professions got forgotten, managers got denigrated, and patients got variable quality. And I think to some extent that remains a fair characterization. We inherited, I think, coming in before the pandemic, sectors that were disempowered in terms of commissioning, and we had institutions in hospitals that were calibrated as a point of public policy to be putting institutional interests above populations and competition above collaboration. That's literally what policy was encouraging. Therefore, we have to respond to that as the sort of realities on the ground. And I think the pandemic showed us the ability, the latent potential for staff radically and rapidly to pivot, to partner, and to prioritize around a set of things that were important. So I think there's no underpinning concern about the ability for professionals and the healthcare sector to respond. But it is worth noting that the routine conditions of our system outside the pandemic systematically inhibit that. So when we think about why, I think I would go to some of the basics. I think the pandemic unveiled for us the basic inadequacy of the infrastructures to support any type of system level working. A lot of the data and information flows, and Ben and I worked on projects through the pandemic on stuff to do with this, demonstrated actually a paucity of information, an inability to get anything like a grip on what was going on at a pretty frightening time. There was an absence of critical infrastructure that is vital for safety. It's remediable, but that's the starting point. And so if we take that latent capability, but in a sense, systematic fragility, I just want to give some final reflections on how we might be pragmatic. So for some of you who've read the Wade Gehry review, you might have sort of, I don't know, you might have had some sense of agreement and amusement at the term that we need to transform how we transform. But actually there's some semblance of good sense there, because if we carry on doing what we're doing, we're going to carry on getting what we've got, and that's inadequate. But I'm intrigued, and I'm not sure I understand what a transformation factory is for those of you who've read it. I think there are 3 lessons that I draw from factories over time. Henry Ford took seriously worker well-being. He capped the working week, and he introduced some more leisure time. Toyota drove safety through continuous improvement of measurement at the shop floor, and they invested in the capability to do that. And the car industry in general put serious attention behind platform technologies, where you can say, get a variety of different outputs, but each and every model has some shared basic core components. We have to take that seriously. The common elements of that are that all of these things focus more on the how than the what. And I think that that is the really key element for any part of innovation. So I'll sort of leave with 3 pragmatic hopes or recommendations for what to do next. Focus on getting the basic infrastructure in place to function as a safe system. Before we get on to bells and whistles, let's get safe care in place, and do that by actively building the capacity and capability of teams on the shop floor to adopt different ways of working. You can achieve that more effectively by taking organizations like mine and helping them to focus around core missions. So I won't give you the alphabet soup, but the NIHR have biomedical research centers. They've got AHSNs, AHSCs, a whole sort of constellation of letters. That is capacity to help, in my bit of the world, Penny and the team do stuff. So we should. That helps build some of that capacity and capability. But in a context where we have to be much more disciplined about describing and managing the boundaries and the roles between what the centre does, what the region does, what the ICS does, what the place does, and what the frontline practitioner does. We have to describe those in a different way. So look, I think if we were to do that, that would be a pragmatic set of next steps. It shouldn't dilute our overall ambition, because as Beveridge said, you know, a revolutionary time of the sort we're in does require revolutionary action, not just a patch-up job. But perhaps building back better is about transforming the way we transform. Thanks.
Thanks, Mark. Really interesting. That's a good thing that guy that said we need to do evolution, not revolution, is gone now, isn't it? Anita, it's on to you.
Yeah, I fear I'm going to be a bit depressing. So I guess, and I'm going to link this back a little bit to money as well, because the government has set out, if you like, the resources that are available up for the next 3-4 years to support this endeavour of building back better. And I think there are, I mean, the bottom line for me is that I don't think the ambitions that everyone's articulated are the right ones, but the resources and the means to do it fall woefully short. And the risks are very profound as a result of that. And I'll just explain a little bit about why I think that. So the first thing is that essentially what the spending review and associated announcements have done with the levy is to assume that COVID is basically over by Easter. And it's absolutely clear that the move from pandemic to endemic is not going to be an event. It's going to be years in the making, and it's going to be extremely bumpy along the way. And so we do actually need to get ahead and plan and think about the sort of resources and way in which we are going to deliver an appropriate and effective response to COVID as it moves from pandemic to endemic. You know, and that work needs to happen. And that will almost certainly mean that the way we deliver healthcare with things like infection control, with social distancing, with the need to be able to scale up services over periods, as we move probably both to embed vaccination, but also with more reliance on treatment, hopefully over the next year, and how we adopt treatments, that all needs to be planned and resourced, and it will affect not just those direct services, but all of our services in profound ways. The second thing that we've got to do is obviously to recover care. And the recovery task is just enormous. So we already have getting on for 6 million people on the waiting list. The NAO added its report this week on the backlog. We've done analysis, kind of loads of people have done analysis. We all do it slightly different and come to broadly the same conclusion, is that there's somewhere between 7 and 8 million people who have a need, who we would have expected to be in our system, who are not in our system. Some of those won't reappear for good reasons, yeah. So the condition has resolved itself. But a lot of those people, if they don't reappear in the elective planned system, will either appear in other bits of our system or will suffer, yeah, and the burden will fall on them with poorer quality of life and poorer length of life, yeah. And so, but to recover what could be a waiting list of over 10 million people is enormous, and the money that's being provided will not enable us to recover to that degree quickly. You know, it's likely to take at least 5 years. So that's going to be with us long term. And then, as everyone said, you know, the dominant feature of healthcare policy over the last decade has been to work our system ever harder and to drive out efficiency, where resources have been grown but lower than the level of demand. Resilience has been sacrificed to efficiency, and it's clear that sacrificing resilience is a false economy, and people who've been here for the whole session will remember that at the beginning, you know, there was a conversation about, will we now see that investing in health is an investment, yeah? And it's pretty clear that not having resilient public services is a false economy, yeah? But resilience will be really hard. It's partly about capacity. You know, we have too few, we're under-doctored, under-nursed, and we haven't not got enough diagnostics, we've not got enough physical capacity. But it's also about the adaptability of our system and the way we train staff, deploy staff, all of that, but also then about the model of care. And just to give a sense of how significant a challenge I think reforming the model of care is going to be, for the last decade, we've had policies in various forms, long-term plan, 5-year forward view, and all the precursors to that, which have been to shift the model of care upstream, more focus on earlier detection, on prevention, on supporting people in community-based settings. Over that decade, outpatient care and inpatient care has grown at double the rate of any other area of care. Social care has fallen, yeah? Primary care and community care have not increased at all. And we've written reams of policy documents. It's been every intent of policy to do that. So all the pilot programs and initiatives that we've had have not touched the sides. Many of them have been great in their own way, but systematically they've not touched the sides. So the ambition remains right, but doing more of what we were doing before hasn't begun to have an impact on that. So we're going to have to do something that's profoundly different. And in all of this, what we've seen is that with all these challenges, you know, the burden is not borne fairly. And the effect of not having a system that can respond appropriately to COVID, not being able to recover, not having capacity, not having that fit for purpose model of care is that inequalities widen. And inequalities risk widening again. And so if we can't do something very different, it is those who are least able to cope who will suffer. But also we've already seen the narrative that the real risk here is that people conclude that it's the model of the NHS that is the problem. And that's the wrong conclusion, but it is a very real risk if we can't turn this around.
Thanks, Anita, for that incredibly healthy dose of realism for us to end on. But it's really helpful to hear, I think, that gap between rhetoric and reality is not something that's new. It's decades old. Right, so let's open up to questions. We've got about 10 minutes. So I might take more than one at the same time if we've got those. So we'll go to Sean and we'll come to the front.
Got confused there, Mark. It's Neil, not sure.
Sorry. Sorry, Neil.
Absolutely fascinating contributions. Thank you very much. Wonder what your thoughts are about the idea. One of the things we could do in Building Back Better is to drop the idea of heroism at the NHS. So NHS staff have universally been heroic during the pandemic. This is not about challenging that. What I'd like to challenge is the idea that we need people to be heroic and that it's good if they have to be heroic, you will. Because it seems to me that some of the challenges we've got about the NHS repeatedly is trying to solve problems and being expected to solve problems on its own, or occasionally thinking about how it draws up organisations or communities into its work for a while and then sending them away again. They're all rooted in that myth. So dropping that and seeing the NHS as something that is a proud but humble participant in work that's done with communities, with wider society, with the voluntary sector, with local government, could help provide some of that resilience that Anita was talking about, which she quite rightly says that money hasn't been given to the NHS to deliver.
Thanks, Neil. I'm going to hold that question and come to the front at the same time.
Hi, and building on what you were saying, Anita, about the kind of the workforce shortages in the NHS, and I kind of want to think about how long it takes healthcare professionals to train. I mean, I'm a medical student, and if I wanted to become a specialty doctor, I would have to jump through an inordinate number of hoops, which are good hoops, and they train for really useful skills on that to do a PhD, kind of do training programs at a national level. But I want to consider whether these are actually barriers and unnecessarily prolong the time it takes good doctors to actually get into the workforce. So I'd be really interested to hear what the panel thinks on, as part of Building Back Better, how we could change medical education, both for doctors, but also for all healthcare professionals.
Thanks for that. Okay, I'm going to come to Penny, maybe for Neil's question first. Yes, sorry, I'm not very good.
I just answered one thing just on your question. So I mean, it's a big topic, as I was going to say, but one bit I'm quite interested in, I wonder if someone could do this analysis. So we've certainly dramatically increased the numbers of medical school places over the last 20 years. And yet that hasn't necessarily flown through into the workforce. And I think that's because the level of attrition essentially has gone up significantly. Certainly anecdotally, that would be my sense. When I moved out of clinical practice, which was in 1992, that was a really rare thing to do. People thought I was mad. Now I have lots of calls from young doctors who are interested in going out to business school or going with private equity or in startups or in pharma companies and so on. So I just wonder whether there's something about actually looking at that rate of attrition and saying, what could we do differently about that? Because my concern is that we pump more and more people in, and even if we change the model of training, unless we address why people are then walking with their feet, we won't quite tackle that. That was one thing. Just to your question, I mean, I completely agree. Heroes is not what we want. What we need is support for people to change. But I think it's doable. Maybe one little thing I look at, which if you look at the rates of, just on Anita's point that we haven't really hit, this aspiration we've all got because we know it's best to look after people out of hospital and keep looking after the hospital. If we look at the absolute number of bed days per head of population over the age of 65, and you look at what many people would say are leading health systems around the world, whether it's Christchurch in New Zealand, or it's the Kaiser health system or the US, or some of the other integrated models in the US, Geisinger, Montefiore, or Sweden, and so on. Interestingly, they've got a very similar rate of hospital use in terms of bed days for older people. And if you look here, we've got a few pockets who've got to that same level, particularly West Dorset being a really good example. And the common characteristic of all of those is they really have changed the model of out-of-hospital care. It's very different culturally, it's very different in terms of the workforce makeup, it's very different in terms of the way in which people practice day to day. And they've got to that level. And that level is about, if you look at the, what it would mean, it does mean significantly fewer hospital beds in this country. So there is something to me which says actually there is something out there that we could all be aspiring to. It's not undoable because all of those places have done it, and they certainly haven't done it through heroism. They've done it through hard work of really thinking through what's a different model of care that actually has impact.
Thanks. Ben, do you want to come in on either of those points about the heroism or the workforce?
Well, I think build on the on Penny's point about not heroes, what I meant by irresistible organization. Talked about meaningful work, supportive management, a fantastic environment, opportunities for growth and trust in leadership. I think the NHS nails in spades the meaningful work. I don't think there's anyone in the NHS that isn't absolutely convinced by it. I think the other 4 areas have got some work to do.
Yeah, I couldn't agree more. It's not really rocket science to work out that the NHS, to be a good employer, just needs to get the very basics right, as we heard earlier. Mark, sorry, I've stolen your mic.
So I think we've probably got a point of consensus. We'd be interested to hear from others later on in discussion. What drives the heroism? Often it's battling against the fact that basic systems don't work. I had to get some notes about what happened to somebody from another professional, and I was on the phone for 4 hours in order to do it. And that was a type of heroism, because then I've made up those 4 hours at the end of the day. I think one way of reducing the need for heroism is just making the design of systems more supportive. And that's where innovation should focus. It should be about doing the basics right. And then when we've done that, we can move on to other elements. I also think, and I think this is probably to Penny's point about how we think about the different model of workforce. There are some, some services that have reimagined what it is to be a sessional doctor, and they've used things like apps as a way of essentially allowing people to work sessions from home. Right, so there are ways of thinking differently about not the technology, but what that means for who can work when and where. And it means that you don't have to have a set of expectations that, you're a doctor and that's it, or a nurse and that's it, and that's all you do. It brings a level of, I think, flexibility into the way of working, which hopefully is more conducive to fulfilling meaningful work, and also less likely to lead to a type of burnout and attrition.
Yeah.
And then Nita.
Yeah, so to the training point, I think this is a really, really important issue. And it is quite interesting, if I take nurse training, that, for example, in the US and in Australia, the number of clinical hours and placement hours that required much lower. They don't ask nurses to select branches so early. There are very different models which could potentially enable us to expand training places more effectively, and also to build a more flexible workforce. And it's also clear that I think in the pandemic ought to lead us to think hard about the nature of training and whether or not we can reform that. Also very interesting to see that actually over the last decade, the number of consultants increased by 1/4 in the NHS, and almost no one believes me when I say that. So why is it that actually the number of consultants increased by 1/4, and yet it's not really touched the sides of people's feelings about workload, etc. Part of that is because actually other staff around that make up the team weren't increased. Yeah, so you feel then, and you deliver care in a team. So having more of one group in a team that's under-resourced doesn't really make the difference. The other thing that I think then is, so I think we do need to make sure that when we workforce plan for teams. And one of the real weaknesses we have at the moment in our system is we plan for individual staff groups, not for teams. and we don't train in ways that really support teams. We have, for example, separate pay review bodies because doctors and dentists can't be in. I mean, how is that? Throughout our system, we just segment, and don't think team. Yeah, so that needs to change. And then the other thing that's happening very quietly, but it's really quite interesting, and we would do with reflecting on, is allied health professionals and new roles are coming up very fast. Yeah, so it's really interesting to see the way that paramedics and what can be done there is really expanding. And the number of people who want to work in allied health professionals is really quite high. I mean, there are other issues. If you take the mental health plan, for example, almost a fifth of the new roles are peer support workers, which are also come again to some of that new model. So we do need to think much more broadly. We need the holistic workforce planning, the team planning. We need to train for team and deliver on a team basis as well, I think.
Thanks, and I think that's a really, really good note to finish on in terms of when we're asking this question about what we do with the workforce, we need to think about the question we're asking and who we're trying to train. But David Behan once said to me, the future of the NHS is not doctors, it's data scientists. There might be some truth in that. So we're going to stop there because I've chaired this terribly. We've only got one round of questions. We're going to move on to the next panel, which is what on earth is going on in social care.
Hi, everyone. So a treat of a session to begin to come to the end of the day on. So really excited for this one. We've got a great panel of speakers to take us through as part, so well put it, what on earth is going on in social care and social care reform and some of the government policy on this. We've joined on my right by Anna Severite, who's a convener at Social Care Future, brilliant organisation doing big thinking on this topic. We're also joined by Richard Sloggett, who many in the audience will know. Richard is Director of Future Health Research and, of course, a former Special Advisor to the former Secretary of State for Health and Social Care. And we're also joined by Fiona Carragher from Alzheimer's Society, another organisation doing some really excellent big thinking on the topic. And she's also a former Deputy Chief Scientific Officer. So with such expertise to my left, to my right, I should probably say who I am as well. I'm Chris Thomas. I'm a Senior Research Fellow at IPPR, but I feel like I should defer to them to do most of the talking. I'll just give a bit of a run through of some of the landscape that we find ourselves in. So if we think about how the last few months have gone, there's been a huge amount of kind of talk, hasn't there? So we can start in September and we get that cap and floor policy, which is put forward as a way to stop people having to sell their homes to pay for care. We get a development then later on in an amendment to the social care bill, I think, where there's a slight deviation from the original cap and floor as proposed by Dilnot that maybe means that the policy slightly skews towards those with large assets, maybe in the south of England.
And then we see, for many of us, something that we've been waiting for a long time, the publication of a social care white paper. I'd love to see some of the drafts that are now probably consigned finally to the permanent white paper then. But something that actually had some really encouraging language and themes and aspirations, but questions over whether, you know, there was enough money, there was enough resource, there was enough political will to take that forward. So those inform the big questions that we'll be talking about here in terms of what do we need to do to make sure that adult social care supports brilliant lives. That's the end point, isn't it? So I'm going to, as we have throughout the day, come to the panelists for opening remarks. We'll take questions, pre-warn those online that to break with tradition so far today. I'll come to your questions first. So do think them up and I'll come to the panel, the audience in the room. And Anna, I might start with you for some opening remarks, if that's okay.
Thank you. So I'm part of Social Care Future, but I'm also somebody myself who draws on social care, and I employ PAs. So it's very important to me that social care gets focused on, and I think often it doesn't feel like it is the priority. It feels like it's often the sort of added on the end after the NHS and after healthcare. But as you say, we did finally get this white paper last week, and I agree, there were some really positive words in there. There was a lot of language around people having choice and control, personalised care, quality care, people being able to stay in their own home for longer. And all of those things I think are wonderful. I think they're things we've sort of heard before, perhaps not so much in policy documents, but what wasn't clear from the white paper was what's going to change to make that happen and where the resources, I guess, are going to come from. So, at Social Care Future, we have a vision that is just about lives, right? And it's really simple. We all want to live in the place we call home with the people and things that we love, in communities where we look out for one another, doing things that matter to us. And at the moment, what we know is a lot of people are not experiencing that. And I guess from reading that white paper, I'm not quite clear how we're going to move towards that. I do think that we've started in the wrong place with the cap and this fixation on selling your home. A third of people who receive social care are actually working age adults, and the majority of those people don't even own their own home. And it definitely feels like we're trying to talk about how to fund care before we've really talked about what that care should look like. The other thing for me is that actually this 10-year plan, this reform as it develops, really needs to be co-produced. The white paper was very hastily done. There were some working groups that didn't really have people with lived experience in them. And I think if we try and design a system that doesn't involve people that actually draw on it in the design of it, you'll just design something that doesn't work. So really what I would say is that we need to be designing a system that allows people to just be able to live an equal life. That's what we're calling for, because at the moment it doesn't feel that way. So that's all from me.
Brilliant. I think those are really important and fantastic introductions to the topic. Richard, I might come to you next, because I know you've been thinking lots about that. How do we do reform question?
Yeah, thanks, Chris. And it's great to hear Anna's thoughts and the work of Social Care Future, which I've been following closely. I want to sort of set out 6 positives on social care, which is not the easiest thing. And there's 6 areas of ambition where I think the white paper should go further. In terms of the positives, I mean, first of all, it is a positive that we do have a social care white paper. Having worked in government on a failed green paper, I was delighted to see finally that a white paper did come out of the other side of Whitehall, which is really good 6. It means we now have a foundation from which to finally work from. I think Anne's absolutely right. CAP is not the be all and end all, but that some of those who do draw on social care do require significant amounts of care costs. Introducing a cap, as we first talked about in 2014, is a welcome move forward, and I think will provide some certainty for certain families. Third, I think if you look at Secretary of State's forward to the white paper, he talks about a journey that is starting. So I think too often we've looked as a fix, something that can be fixed. I don't think you can fix social care. I don't think that's actually possible. I think it is about going on a journey and actually trying to work in a new, dynamic way. I think that language is really, really important. I think there's also a strong focus, as Anna says, on the personalisation piece, moving away from very transactional ways in which care is commissioned and provided to much more personalised and person-centred care, so what matters to people and their families. Moving away from quite traditional models where people think of social care, it's often, we do often drift into talking just about carers. I think what we need to do is actually be massively ramping up the amount of care that people can receive at home. If we're going to deliver more personalised care of people living the lives they want to lead, we need to be doing that. So I think, again, that ambition is really, really welcome. And there was some funding, there was some money for workforce development, there was some money for housing adaptations and some money for new technology. So I think there were some positives that come out of the white paper that do provide a platform for policy reform and policy debate. However, I think this white paper could go further in a number of areas, and I picked 6 where I think actually the level of ambition needs to be raised. If you look at the NHS long-term plan, which came along with it several years worth of significant funding uplifts, it had targets in it such as going to diagnose 75% of cancers at stage 1 and stage 2 by 2028. We're going to save thousands of lives from cardiovascular disease. This plan doesn't have that kind of teeth because it doesn't have the requisite resource and investment in order to make those sorts of claims. I don't think we can get away from the fact that funding and resource is going to be absolutely critical to deliver on some of these very well-meaning ambitions. Other areas that I think the ambition needs to be raised, let's take some in terms. So first is housing. There is some money in the document for housing, adaptations, etc. But I think there's a massive agenda here of housing and care. We want to build hundreds of thousands of new homes in this country, but seemingly devoid of joining this up with the demographics and changing care needs of our population. If you go to any event building new homes, it's very rare that you get questions or engagement on social care. That debate and agenda desperately needs to be joined up, and we need to be seeing the Department of Health working much more closely with the Levelling Up and Housing Department to make that happen. In the report, Fiona, Some Society and ourselves put out a joint report about 3 or 4 months ago. One of our recommendations was that actually there needs to be much more work done on the housing and care piece. On technology, great to have money for adaptations to keep people in their own homes, that's absolutely welcome. But as we heard from the last panel, we really need investment in infrastructure. And what I mean by that is it's investment in joining up data and information across different services. It's far too difficult, far too complicated at the moment. People do not get that person-centred model of care that they need because different agencies that they're around do not talk to one another. And that is a fundamentally an infrastructure piece that we desperately, desperately need to see. And again, I think the white paper could go further on that. Information and access to information. Again, there's a small pot of money, £5 million, to create a national website platform of information on care reform. But as anyone who's tried to access care services knows, it is a very, very difficult thing to work out what you are entitled to, what is available, what good looks like. And again, I would say that there is a much larger piece of work that the white paper should be kicking off in relation to what information is available to people who access care and actually assess it a bit, helping them assess what that care looks like. The 5th point I wanted to make was about provision. If we're going to provide more care, we're going to need some people to provide and deliver it. Now, we've had a lot in this conference about workforce, which is absolutely critical. But I also think that fundamentally the social care provider market is in desperate, desperate need of a new look. Anyone who watches the BBC Panorama earlier this week will know that some of the funding practices of care providers are, shall we just say, less than adequate. And if we are going to deliver the care that people need, we're going to have to encourage and incentivise new providers to come into the market, seeking to provide new types of care at home. I would strongly support, and it was in our report, a review of the social care provider market, some of those practices that are going on, and actually looking at ways that we can actually stimulate a better market for people to provide higher quality care. Finally, I wanted to come and talk about the levy, because clearly it's critical. You wouldn't have a cap without the levy. Most of the health and social care levy money is going to the NHS elective backlogs. We have plans for integration white paper, which Matthew Taylor mentioned in his keynote address, which has been apparently delayed to the new year. It's very unclear at the moment how funds for the NHS backlog will then flow into social care. That is highly unlikely. I don't think the NHS has ever returned money to government that it has been promised. Now, integrating those two services will provide potential opportunities to share and pool resources, but the the idea that integration delivers efficiencies and savings is still very much to be seen. And I think there's sort of clarity that is desperately needed around the levy, how that levy is going to work for social care, and where any of that additional resource is going to come for some of these items that I've listed. So the white paper, I think, does move us forward. We now have a document which we can scrutinise, engage with, and look at. But there are clearly some areas, I think, if you're setting a 10-year ambition, that we can go a lot further on.
Brilliant, thanks, Richard. And I think it's great to start on the, you know, the good to balance out the challenges as well. So thanks for those remarks. Fiona, to you next.
Thank you, and thank you to the IPPR for inviting me here today, and actually building on the comments that Anna and Richard made, agreeing with a huge amount of what's been said already, but thought it was helpful to give some context around dementia and the people affected by dementia who are the biggest users of social care. Now, I sat in on the NHS session, and it was really interesting, having been a clinical scientist for most of my career within the NHS, and then kind of moving across to Alzheimer's Society. It's almost compare and contrast with dementia, because where research, innovation, science has taken us big leaps forward in cancer, in cardiovascular disease and stroke, we have yet to see that coming through within dementia. So despite being the UK's biggest cause of death, there are currently no treatments that will stop or slow progression of the diseases that cause dementia. And if we remember that dementia actually describes the symptoms, so memory loss, difficulty concentrating, personality changes, it doesn't describe the diseases or pathologies underneath it. And we also have to remember there's some real myths and lack of understanding across the wider population, but also health and social care professionals. Dementia is not a natural part of ageing. It is more likely in older age, but it's not inevitable with older age. And we also know the impact of dementia is growing. So there's nearly 900,000 people with dementia in the UK at the moment, and that number's set to rise to 1.6 million by 2040. So really striking numbers of people that currently get most of their care within the social care system. And actually the interactions with the NHS are relatively small. They're at the point of diagnosis, often within memory assessment clinics, within mental health services. And at that point, once you have your diagnosis, you are then discharged home. Many do not have very good or any post-diagnostic support. And actually their interaction with the NHS is at moments of crisis, falls or infections, when people often have to end up within acute care. So the majority of people with dementia will rely upon a social care system for their ongoing care and support, not just for themselves, but for their family. So just kind of giving you some COVID context, because I think it's really important, and neither Richard or Anna have kind of given the context here. But we have been in some ways in crisis within the social care system for a very long time. But the last 21 months, and the whole COVID crisis has shown us writ large. At Alzheimer's Society, we've talked about people affected by dementia being the worst hit. Because 1 in 4 of all deaths from COVID-19 have been from somebody with a pre-existing dementia. The impact of isolation and lockdown on people with dementia have been an increasing decline in their cognitive ability, which means that they're more likely to need increasing support. But also there's a hidden story here, and that's the one of unpaid carers that we may come on to discuss and debate around social care, because they are burnt out. We're hearing day in, day out from hundreds and thousands of carers who are just on their knees, not being able to access the support that they need. So what happened at the beginning of COVID was very clear. Right from the Chancellor promising everything the health service would need, the NHS gets whatever it needs to survive this crisis. But social care, where the majority of the 900,000 people with dementia rely upon, was absent from those initial conversations. What we saw was that care homes were primarily seen as a means of easing pressure on the NHS. We saw right at the beginning of the pandemic people being moved out of hospital beds into care homes without those COVID testing. And we also know that care homes, domiciliary care, personal assistants really struggled to get the PPE that they needed at that beginning. So if there was ever a burning platform for social care reform, the COVID pandemic has absolutely shone a light on this. And one thing that we've really kind of been reflecting on as a large campaigning charity is that we recognise now that social care reform is not going to be an overnight change. Like Richard said, it's got to be this long-term process, and it will be iterative. I've been always very proud to have worked in the NHS, but if you look back to what the NHS looked like in 1948, it's very different from where it is now. So the whole point about the white paper and social care reform is that this is the start of the change that we're needing. The other point I think is really important to make, and I think builds on what Anna said, is that we talk about the system a lot. The system needs this, the system is doing. Actually, this is about the people who draw upon social care for the support that they need. And we have to really drive that conversation around the ambitions around social care reform. As I said, with Future Health and with Richard, we did put out a report in September called Stabilise, Energise, Realise, which set out this long-term vision, thinking about what we need to do to have that workforce in the first instance, making sure that we use technology, innovation very different in the future, but ultimately people being able to lead the lives that they want. So the white paper, there was some really good stuff in it. There was a lot of talk about giving people choice and control. There was talk about quality, really importantly about quality, about personalised support. There was talking about ensuring care is fair and accessible. And there was talk about ensuring that care is person-centred and not just focused on the tasks, which is often what we get within social care at the moment. But we are concerned that that's what it was talk. And what's really important, I think, is the funding that needs to follow this. The money that was allocated to social care reform is nowhere near what was needed. The funding announced last week to accompany announcements was just 1.2 billion to cover the next 3 years. That's £400 million per year to really achieve these ambitious aims is nowhere near where it needs to be. So one of the things I think we probably will come on to is the levy. Social care is not going to be getting the access to that funding for the next 3 years. Well, what does that mean? Because we need to stabilise the system now. So finally, I think just to kind of build on, I think the excellent work that Social Care Futures have been doing, I think we absolutely support the vision that to transform our social care system, it is about the people. It's enabling them to live in the places that they want, to do the things that they love and enjoy, and to continue to live the best lives they could possibly. And that is exactly what people affected by dementia tell us day in, day out that they need. So thank you.
Brilliant, no, thank you so much for those remarks. So I said I'd come to the virtual audience first for a question. We have one, which is that the white paper makes kind of a commitment around housing-based care. And the question is whether there's a role for options like extra care housing, retirement communities, and how you increase the supply and the quality and the diversity of the options on offer. I'll do a chair's prerogative question, come to one from the physical audience so that we've got a round, but I'm really interested in whether people think that the narrative is changing in an encouraging way, whether the kind of focus that we've had on or that's been pushed particularly by Social Care Future is a good example of this, because a more optimistic vision of what care can provide rather than one that's always about crisis, whether you see that having an impact and starting to change the conversation, the kind of things that are considered possible. I don't know if anyone in the audience has a burning question to throw into this round. Maybe we'll start there and come back to you. Richard, maybe to you first on housing, because that came first and you mentioned that.
Yeah, I just feel that the housing piece is just not joined up properly, and I think there's actually, even with the NHS and housing and population health management, I think there's huge opportunities. We know there's a really good Paul Brand ITV documentary actually on some of the poor quality housing that people have to live in this country. I think if you could genuinely get the housing stock into a better place, and you can actually increase the level of the amount of houses that we're building, that can give you an ability to provide care in a range of different settings. Now, the white paper is very good on the ambition of wanting to move away from those traditional models of care, those residential care settings, which we're still going to need, but we really do need to be moving in a different direction. We need to keep caring for more people in their own homes and making those homes safe and care ready. Now, when we're going through that process of building those homes, we need to be looking at our population and our demographics and the need and working out how we build those homes in that way. Other countries obviously do this very well, particularly in parts of continental Europe. I just think this is a classic challenge. We've got to join up bits of central government and empower local government to go away and take the lead on it. So it's welcome that there's some money for supported housing in the white paper. It is only £300 million, and it's a small amount of money when you look at the 150 local authorities who could potentially bid for that cash. So, but I do think you could do a lot more of this agenda, which would actually deliver on some wider ambitions of the white paper.
Yeah, really interesting. I'll just come down the line and go to you next year.
I think there's a few points to make on that. I think the first is to say that what we know and what we hear from people affected by dementia is that they want to live in their own homes for as long as possible independently. And actually what often happens is that they have to find alternative homes in moments of crisis. So, you know, a not untypical story is that someone will end up going into hospital from a fall or an infection. They will deteriorate within the hospital setting, and then there's not a care package which enables them to go back home. So it's a crisis point for the family then to have to find residential care. So I think there's a whole piece around crisis management, around pre-planning that's, I think, incredibly important within this as well. I think the other point I would make is that, you know, one of the things that we suggested within our policy report in September was that we could think really innovatively around this. In the same way as the Life Sciences has a sector deal, to have a social care sector deal that brings together public and private money, thinking about philanthropy in a way. Actually, if you look to the US, philanthropy plays a really big part in some of the really creative, innovative roles and innovative ways of doing that. But also, how does the innovation and technology agenda play into this? So again, thinking about it from that kind of sector deal perspective in terms of UK PLC growth. And I think the final point I would make is that there are some really great international comparators here, international examples. The Netherlands, for example, has got Tante Louise, which is a kind of an Aunt Louise, but it's a really wonderful home environment for those with dementia diagnosis who that can adapt as the disease progresses. So I think I agree with Richard, there's a lot more that could be done in terms of being ambitious. But I think that we have to start with the kind of reality of what people, particularly with dementia, are facing.
Yeah, that's really important. And two interesting ways into those questions, I think, Hannah, in terms of one, a place we call home, that's quite interesting from the home's perspective, but also the shift in the narrative and whether you feel like the social care discourse, to put it like that, is changing in some way for the better.
Yeah, around housing, I think COVID showed us all how important actually our homes are to us, that they are a safe place, and they're also often the place that you have roots and connections. You're part of a community, and I think it's really sad that often people lose that as well at the same time as having to move. And as Fiona said, it's often in a crisis. I think the challenge is around psychology, really, of aging as well, and of people don't want to think ahead that much. I think my parents joked that now actually their house is quite age-proof because they've adapted it for when I come and visit. But actually, joking aside, that actually may be helpful for them as they get older. And how do we have a conversation like differently as a country that we talk about our plans for the future? Not that, you know, to detail, but just that actually as we're building houses, there are still new build houses that I cannot visit my friends because they're built with 3 massive steps up to them. And you think, why are we building houses now without basic accessibility built in that then can be easily adapted later? Surely that's sort of basic things, but I think people need to have, I think we need to think about prevention with housing as well. So a lot of people have actually got quite a lot of support networks out there, and we need different roles. So people like community circles, like connectors that would come in and actually like link up some of those informal networks that are around someone at the earlier stage, rather than wait until they're in hospital at a crisis and then nothing could be done and they have to go into care home. That wouldn't have been their choice. So that's the housing. And then around narrative, I think the white paper did use some very different language. It had a lot of the I statements for making it real in it, which was really positive. It didn't talk about social care looking after our most vulnerable, which I actually don't particularly like that as a term, because I think it labels everybody into this lump, and actually people have agency at whatever stage of life we're at, and with whatever condition, there's a degree of that. So I think it did show some shift. I think the sector is still quite behind on that a lot of the time. You still hear quite a lot of traditional talking about, I'm in meetings where people are talking about number of beds and not people. Like, these are people, they're not like beds in a home. So I think we're on a journey, and I think we've started it, and there's some progress has been made, but we need to continue it now and keep going.
more to do.
Yeah.
And time for another round of questions. Anyone in the physical film got a question I'd like to bring in? Yes.
We've had quite a lot of commentary about the white paper kind of visions looking forward, and respective judgments on that. See some good stuff, lots to improve on. We're also facing at the same time as kind of looking down the line, also facing some really acute crises in the social care sector. We've talked a bit about workforce earlier today as the biggest issue facing care and health services. What more can we really do as a sector to really tackle those crises that are there in the here and now?
Yeah, I think that's an excellent question. Questions that I'm going to bring together from the online chat as well, which really around the value of care. So how can, we haven't talked much about the kind of paid care conversations, so the kind of what should someone in social care work be paid. So thoughts on that, welcome. There's also a question on unpaid care. So how can we make sure that the work of unpaid carers is taken into account? And particularly that question focuses as well on its racial and gendered elements, so the kind of capacity for inequality there. Maybe worth going down the line the other way this time. And Anna, keen on your thoughts around that kind of question on crisis and also that question on the value of care.
Yeah, I think historically, clearly care work has not been valued enough, and it's sort of been seen as a low-skilled job, which I don't believe it is. But I do feel that a lot of the workforce debates are quite they're very led by the sector, but actually I really care that the people supporting me get a decent wage and have a good quality of life. And I feel like it would be a much more powerful, I don't know if you want to call it campaign, but actually we should all be working together towards this, because actually everybody benefits from having a workforce that is sustainable, supported. I don't know how to, pour loads of money in so everyone can be paid more. It's interesting for me that I pay a lot more than most agencies I know do, and that's because I've cut out all the middlemen in a sense. I haven't got the management, I haven't got the shareholders, I'm just me, so I can do that. But not everybody's in that situation that they want to become employers, and I understand that. I think one issue is that whenever I hear the sector saying we've got a workforce crisis, they then say, and it's a really hard job and people are underpaid, and they make it sound like this horrendous job. And I think, well, no one's going to want to come and work in it. So I think we've got to start talking about actually what the good opportunities are in social care. And there are some great roles out there and the difference you can make to someone's life. And if we start telling some of those stories, hopefully if you spoke to my PA today, you can afterwards if she'll agree, she would say she enjoys her job, I hope. And we need to hear those stories and not just hear that it's a really hard job, that it's really awful and underpaid, and because no one's going to want to come into it. The unpaid carers, I think it's really vital. If we don't support people at that stage while they are at home, often saving the system tons of money, then you hit a crisis, and again, you then end up with the loved one often having to go into residential care. If we provide a bit of proper support early on and not just a carer's assessment that gives them a £50 voucher, then we can often allow people to stay at home for longer.
Yeah, really important. And I like the risk of, talk to her after, and we'll see what happens. We'll see. Fiona, you mentioned unpaid care. Interested in your remarks on that.
Yeah, so on the unpaid care piece, I mean, there are 700,000 plus unpaid carers for people with dementia in England. And we know that they have really kept things going, particularly within this COVID period. We also know that they're often not identified and not supported within the system. So one of the kind of simple things that can be done is to understand who they are, and then to be asking questions about how can we support you more. I think that's kind of one sort of straightforward thing that actually could be done quite quickly. But there is a big economic issue around unpaid carers as well that I don't often think is discussed. And that is that many unpaid carers or many kind of informal family carers are having to give up their own jobs or having to work part-time. And I think there is an equality issue here in that the majority of carers are women. So again, there's kind of an equality lens around that as well. The other issue in terms of staffing, I think that, you know, what we've seen through this COVID crisis is the wonderful care that is given in so many cases. In care homes where families were unable to visit, it was that relationship that people with dementia had with their carer that really kept them going through this crisis. But we've also seen the impact, as you say, of you know, people being burnt out, the vaccination issue on top of that as well. So I mean, we know that what needs to happen is that we value this, so that very positive narrative about, you know, a caring career being a really wonderful career to have. There's huge issues we think around training, particularly around the specific nature of the training needed for dementia, and to understand as the disease progresses as well, the changes that may be needed in the care. But I think there's an opportunity when we think about the integration agenda to think about how we start to put social care and the care workforce on that kind of equal footing with our health and NHS workforce. I thought Neil's question was really interesting about being heroes in the NHS. I don't think our care sector staff have been thought about in that same way, and they have been doing heroic work in the same way over this pandemic. So there's something about public discourse about really valuing and kind of holding that up as a career that we want to encourage our young people to go into for the future as well.
Yeah, really important. And Richard, over to you for a final word.
Yeah, I think it's a great question. I was delighted that I got it last, so I can follow those two remarks, because when you look at the difficulties that the social care system has at the moment, they are very, very acute. It's very, very difficult. In the medium term, in the report that we worked on the outside society, we sort of looked at I think workforce is the most important issue, because if you don't have any people, you can't. It's obvious. And we looked at a four-part approach. We've got to retain what we have. Some of that is about paying conditions, about value. We have to try and attract. We have to position ourselves. I think Anna's reflection is a really good one, which is we won't attract people and talk things down, but we have to have a degree of realism about some of the challenges that people face. I think some of that is also about celebrating really good care. There is some really good care being provided out there, which often goes unseen, which is, when I was doing the report with the Outside Society, some of the people I spoke to were doing absolutely amazing services under very, very difficult circumstances. Training, there was some money in the right paper for training and development, which I think was highly, highly welcome. And Fiona's point on progression and that ability to put parity between the two systems, which you could see coming out of a move towards an integrated care type model, I think is really, really important. I do think there's the real role here. I think the theme that you get from the sessions today is there's a much stronger role for government workforce across health and social care. And that's what's really lacking here. We have a soft centre, I think, called workforce planning. We've had lots of draft ideas and strategies, some of them very well put together. Health education in 2017, it's over 100 pages. I go and read it, and there's loads of good stuff in there about the future of health and care workforce. Never really got out. We're only going to make progress on workforce of central government hence this argument today. In the report that we put together, we did have some ideas about what that could look like. We suggested actually that, for example, in pay, again, there should be a role in the central government to oversee pay conditions of staff within particular care facilities. There is a role for CQC in the Health and Social Care Bill, providing assurance of local authority commissioning of social care, which is a good opportunity to kind of deliver some greater accountability of what care is being commissioned, being provided. but I think central government needs to take greater ownership over the workforce doing it across not only social care, but also the NHS.
Brilliant, and thank you for that. And a huge thank you to the three panelists, Anna, Fiona, Richard. Really appreciate your thoughts. I think it's a brilliant time to be having the conversation around, you know, what's going on, what's happening, how do we talk about it, how do we balance the acute crisis with the optimism that the future might hold. So huge thanks. We have a final session next, and I think a really nice way to end the session. So we'll be giving you an exclusive screening of the short film Limbo. Limbo is a film that keeps us on the social care topic and talks about some of the deeply personal stories of social care through the eyes of a care worker that we saw during the last few years. It's 15 minutes, it's really powerful. I really recommend staying to watch that. If you'd like to have a glass of wine or some nibbles while you watch the screening, then please do help yourself at the back. At this stage, if you grab a glass, bring it back to your seat, and then we'll reopen the free bar for a final drink and some chat and networking after. We're also delighted to be joined by the filmmaker of Limbo, Loche, who's kindly agreed to do Q&A with Pierre, who was a care worker who came to London from Paris 5 years ago, and from Paris to London, and was the inspiration for the film. So some really interesting perspectives, and we'll dive into some of the topics and themes. So do help yourself to a drink and join us again in 2 minutes. We'll just switch over to the film now. Those on the virtual session, we haven't forgotten about you either. We'll have a link in the chat for you to watch along with us. Do grab your own glass of wine so that you can watch along, and we'll see you in 2 minutes to watch the film, and then about 15 minutes to come back for Q&A. Thank you, Anna. That's brilliant. Now by Leger and Pierre for some question and answer and some in conversation. Yeah, maybe those two. I'll take this one so I can see the laptop. Brilliant. So I think we'll have participants coming back to us from virtual screening as well. But a huge thanks for having us screen that today. I wanted to start just by asking two questions really, and I'll start with the first, which was really the inspiration. So what was your inspiration in thinking about putting the film together? What were you hoping to portray and to achieve with the work as you produced it?
Thanks so much for inviting us and for the opportunity to screen it here today. I've always been sort of struck by the situation that elderly people find themselves in, and yet, you know, we're all kind of going in that direction. So I've always sort of had that in the back of my mind. And then I had a really serious brain injury a few years ago. So I was myself a recipient of care during a really long recovery. And so I sort of saw things from that perspective, from, you know, the vulnerability, the confrontation with mortality, and being part of in my case, the NHS system. And so I was really interested in that experience as well. But then obviously I recovered, so it's not the same at all as an elderly person's experience. But Pierre, who's my partner, became a care worker and saw things from the care worker perspective. And the stories he came home with about his experience, which he'll talk about, really fascinated me. And I you know, a lot of the stories we hear in the press, or we did pre-pandemic, which is when the film was shot just before it was shot at the end of 2019. Were often quite negative about abuse in care and so on. I really wanted to show the challenges of the job and also the potential that there is for really building kind of a very touching and in a kind of beautiful relationship between carer and recipient that is kind of destroyed by the limitations on time and the really terrible conditions. I know the earlier speaker talked about the positive side of the job, and Pierre will talk about that as well, but the conditions in which carers have to operate and the pay that they have to live with. So about that conflict, really.
Yeah, I think it's fascinating, and I think very interested in the process by which you kind of came to the storylines that you portrayed. But maybe, Pierre, it's first useful to go to your experiences of care work and, you know, how you found coming into the sector in London and how some of your experiences might be reflected in the piece that we've just seen.
So when I came to London, I was doing photography and I needed a part-time job. So I want to do something meaningful. And I thought I volunteered in the past in India, and I really love working with people. So I thought it could be the perfect job for me. And at the beginning, it was really amazing because you meet these elderly men and they have so many stories. And I think it's like, it has an amazing potential because it's what everyone is looking for, is to connect with people and to have something meaningful. I think everyone is trying to do that in life. But then when you work, you realize that it's hard to connect with those elderly men when your working conditions are impossible. I had to go to people home with my bike, like the actor. And for example, you would finish a shift at 12 and you have to be at someone else's house at 12 when there is a 20-minute bike ride. And you start at 6 in the morning and you finish at 10 in the evening to have like a day of pay, of like £60. So when you arrive at people home, you're already late, they're upset. So it's hard to create relationship with people when they're upset, when they keep seeing new carers every day, because people keep quitting their jobs, obviously. So some of them have dementia, some of them have other problems. So it's very unstable, and it's like a steaming situation where it's going to explode. And I think this is what I tried to show in the film. where after 3 months, I realized that I couldn't offer care and compassion to people because I was just tired. And when you start to be tired and you have people who have difficulty, eating, or you start to lose patience in a way. I found myself becoming frustrated with the people I was caring for. And so it was horrible. So I just thought I better stop now.
Yeah, and that gives a really good insight, doesn't it, to some of the inspirations for the short. And I'm really interested in thinking about the kind of different inspirations that came in, the stories that fed into the portrayal of the social care worker, but also into how you thought about and mapped up the stories of the elders that were shown as well. So I'd be really interested in how that came together into the piece, into the single piece that we saw, and how you found and tried to be true to the stories that lived experience that people had.
Yeah, well, I originally wanted to make a documentary because that's what I used to do. But it was just so hard to find carers who had the time and the interest. And obviously there was the ethical questions around filming very vulnerable people with dementia or other, serious degenerative diseases. So that's why I sort of decided to make a scripted film, and I just created the character of Vitold, the care worker, based on Pierre's experiences, but a kind of light version, because a lot of the reality of the situation, I wasn't able to film with those vulnerable elderly men in a way that, would treat them, in a way where I wouldn't manhandle them. You know what I mean? I wasn't able to tell the true horror of the situation, the true intensity of the physicality of the job, but a version of it. And then I was searching for about 6 months for elderly men who were living in isolation. So obviously that was quite hard because I was looking for people who were living in very lonely, isolated situations. I found them through organisations that do, there are these amazing organisations around London that are just sort of hidden and you never really hear about them. Some of them are faith-based, but some of them aren't. Some of them are partly funded by the government, but that funding is always dwindling every year. And they helped me find those gents. And then I had to build a relationship with them, a relationship of trust, so that they felt comfortable telling me about their incredible long lives, and they had fun with it as well. So we both, we all enjoyed it.
Yeah, no, fantastic, and I think the process feels really important in a film like that, doesn't it? And Pierre, interested in coming back to you because there's a sense, isn't there, of the potential for things to be different in that short. How much of that did you see? Because we've talked a lot today about the story of social care that we want to tell is one in which people who draw on it experience brilliant lives, and that could be the case in many cases. It's not, and we've seen the cases that it's not there. But how did you see the opportunities for that, and what do you think some of the biggest challenges were in achieving it? Do you feel like there were some barriers that particularly stood out in your work?
I think the lady was saying it's important to show the positive side of care to attract people. And she's right, because there are amazing positive things. I think there is no unemployment in care. You can always find a job in London tomorrow and start as a carer. So this is an amazing opportunity. It's like a meaningful job. You can connect with people. But at the same time, you have to change some things. Otherwise, people won't stay. My training was 5 days. 5 days to learn about dementia, to learn about all these things. And in 5 days, at the end of the 5 days, you have an exam. And I realized that actually it wasn't about the content. It was about taking pictures of what they were showing us on the screen and to be really fast at finding the right answer. So they were just testing us to be as quick as possible, to see if we are able on ground to do the job really quickly. So it's about speed, when these people are very slow. So you have this contradiction of speed and slowness. So I think have a proper training. I think it's very important. And also stop paying people by visits, because you are paid for 45 minutes. For 1 hour of work, I have to be outside an hour for transportation, plus there is this moment we have nothing to do, 10, 15 minutes. So it means that you are paid half the minimum wage in London. So if you have to find a solution to make maybe, I don't know, like a package, you are paid for the whole day, and then at the end of the day, you have a decent pay. And then the relation you have with your managers as well is very important, because they have high pressure, the people working in the offices, because they keep receiving calls from the elders who are waiting for the carers, and they're very upset. So then they call you and they put you pressure. So it's like a vicious circle. So I think if we manage to find solution for each of those steps, because it's nice to say to people, care is a great job, and then when you're there and the job is horrendous, the conditions, I don't see the point, you see. I will ask you, would you accept these conditions, these working conditions?
Yeah, and I think
I don't think people will accept that, you know.
Yeah, and I think we've seen court cases going through, and the kind of sites of exploitation are definitely there, aren't there? And we see that kind of unearthed all the time. It adapts so quickly, so it's new sites of exploitation each time, because the terms don't change as a kind of power dynamic. I mean, really interested to understand what the move was like as a filmmaker as well. So I think there'll be people definitely in the room that have seen My Beautiful Broken Brain and some of your other works around that. Did you see any difference in something that had, kind of a story of recovery and the interaction with the NHS to moving to social care as a different thing with its own story?
And
So the difference between, I suppose, thinking about the topic of National Health Service care and social care as a very different space to be operating in, how you told that story.
Well, when I was recovering, so that experience was a very sort of subjective experience of recovery within the NHS system. And it is really different to what Pierre is talking about. But there are similarities in terms of people being overworked, and, people really doing their best and really, showing compassion, but not really being able to deliver it all the time, just because of the pressures on time and the limitations on resources. So as a stroke survivor during that recovery period, which was really, really long and complex, and I went through lots of different stages with lots of different bits and pieces, you really feel that sense of alienation and loneliness and isolation that perhaps the elderly people feel every day. That is to do with, a limitation on resources, which is what the NHS is dealing with. But on the other hand, you see the incredible care and compassion and the ongoing commitment that people have committed to. You see it in certain people, and in other people you see the sort of dead eyes. So it's just, so that was very subjective to my experience.
Yeah, and interested in as well, and come to questions after this, so be ready with them, but just the reception. So I know I'm interested in how it's been picked up by audiences, but also there's an advocacy message in there as well, isn't there? So how you'd ideally see the film, in that advocacy role as well. So yeah, two sides to its pickup. How has it been seen by audiences in places you screened it, and how has it been? How would you like to see it used in changing conversations like this, but also just wider policy and thinking?
Well, this year it's basically been going to film festival, which is great, but that's a very insular world, the film world, and it's not really, it's like what people are moved and interested in. But what I want is for the film to be screened and used in places like this. And I have had a few screenings and kind of events, not dissimilar to this one, where people are using the film to really highlight the situation, reality of it, and actually bring some emotion to it, because we hear every day about the problem of care work, the problem of isolation amongst elders, but hopefully the film brings some emotion to it so that we go beyond those facts and statistics. So ideally, I would love the film to influence policy to improve the situation, but it has to be seen by the right people. We're quite close today.
Well, let's open it up to all of you, the right people, and to those watching live. Any questions on the content? Wow, lots. So we'll go at the back and then to Tom at the front for the first wave.
No, I just wanted to say, there was a practical question about you as an artist, set in the context of, so you're highlighting the role of carers at a time in which that market is really impacted by the pandemic, but so is your work as an artist and a filmmaker. So I just wondered if you could tell us how we could find you or support you, which I think is an important question to ask. And the second one is just to say, and I have a question at the end, I come from the campaigning side of policy work, and the kind of work that you do is what we would describe internally as immersive campaigning. And it's actually an incredibly important political tool to get someone to cross the divide from a total failure to understand an issue, and one in which it resonates in a way which converts them and generates interest to the cause. So I congratulate you on that, but I want to know, what is the next thing you're going to turn your lens to?
So the second, let me do the second question. No, let me do, what was the first question again?
How do we support you?
Oh, thank you so much. Well, basically this short film that you've just seen led to a commission from Film 4. So I'm writing a feature script at the moment. And I do have this hidden disability, which is that I still can't read following my brain surgery. So I'm writing a feature-length script without being able to read. So it's quite an interesting challenge, but I'm very grateful to Film 4 to support a disabled filmmaker, basically, and really excited about that. It's about a young woman trapped in a kind of coercive, controlling relationship. Yeah, so exploring that. And then the second answer, what's
I've already answered it.
Yeah.
It was what next?
Oh yeah. But yeah, if you'd like to use Limbo for any of your campaigning work, you'd be so welcome. So yeah, I think you'll find my website on the blurb around today's event, and you can just get in touch.
We'll make sure everything's shared as well afterwards for everyone who wants to pick that up. I think we're going to go next to Tom at the front.
There are clearly some influencing policy ambitions around this film. I wonder if there are also some cultural ones, because you said you were really interested in the experience of aging, and I know that lots of other countries have, and lots of different cultures have different ways they approach and deal with and think about aging, some perhaps healthier than others. And I guess I'm just eager to ask you rather what you think is like the ideal cultural and societal approach to that, how you would see it in an ideal world.
Yeah, we talk about this quite a lot, because you see in more southern cultures, even from Italy and Spain down to India and the global south, that there's a very, very different relationship with the elderly, and you have these multiple age groups living together in the same home, and the younger generations looking after the elderly. So it's a very different setting. But then there are obviously problems with those you're quite limited in terms of your own personal freedom. So it's not perfect in that way either. So we debate, what could be the perfect scenario. And I just think, I feel like I only really know the UK situation. I've lived in the Netherlands as well, and I know that it is a little bit better there. But I think it's something to do with the lack of kind of funding around making those last years of people's lives valuable. So, people dedicate their lives to work and family, and then at some point everything is gone and you're all alone, and you're either in a care home or you're receiving domiciliary care. And it's just, that the value of that life that you've lived is just kind of disappeared, and there's just so much tragedy to it. But I think it's to do with the lack of funding, because obviously the elderly are not contributing to the economy, and they're in fact seen as draining the economy. And then, and that's perhaps why there's so little funding for care work as well. So that whole situation for carers and for the elderly, they're just kind of left to sort of sit there in a pile of poverty. Sounds horrible, but yeah, there seems to be very little value basically in those people, those men and women doing those jobs and receiving that care. So I don't know what the answer is, but I think money might have something to do with that.
Was that accurate, Pierre, to your experiences, that you felt that the kind of ways that we think about value in the economy, and particularly, kind of the ways that we think about contribution, that was underpinning some of the negligence, or in the ways that 45-minute appointments, we know there are 15-minute appointments, that those were being designed and operated, that it was a cost containment exercise rather than a meaningful flourishing lives exercise.
For me, it's not only about the money, it's about the value of what is to be old in the Western world. Because when I was doing my visits, I had people originally from India, people originally from many places going to London. And I noticed that it was very different depending the culture. And I think in the West, it seems to be like a horrible thing to get old. And I think it's a bit sad because those people have amazing wisdom, they have amazing knowledge they can share. And we don't value that. So we put them in a little box. Whereas I think in some cultures, maybe like in southern Italy or in India, for example, we still value the fact of being old because these people can bring something to society. So that has nothing to do with money. It's really a willingness to acknowledge these amazing things and everyone is getting older on top of that in the society. So we have to, to change that, to change this way of thinking. So I think this is very important as well.
Indeed. Any more questions from the audience? I've got one over there.
Thanks so much. Firstly, congratulations on a fantastic film. I really thought it was brilliant. I've got two questions for Pierre, if that's all right. Firstly, I'm looking at the screen and I'm wondering, Pierre, do you have a cameo as the bicycle thief? And then my second question, more seriously, is that I work in the NHS in policy role, and I know that when access to NHS services is lower, people can't get access. That leads to frustration amongst the public, understandably, and often that translates into both verbal and physical abuse towards clinicians and healthcare staff more generally. We've seen that happen in recent years. I would imagine, I'm assuming that that's the same in social care, but I don't know that. So I'm wondering, Pierre, from your experiences, has that been quite commonplace when you've dealt with clients and service users, and what does that look like from the experience of the care worker?
I'll just repeat for the audience, that was, did Pierre have a cameo in the film, and what's his experience been of kind of frustration or the conversations that we know go on in the NHS around verbal and physical abuse?
So yes, I was the bicycle thief. And the funny thing, when I took the bike, a woman ran after me. She said, "This is not your bike." You see, amazing people in London. So, and to answer the second question, yeah, you're absolutely right. When people are frustrated, they start to be aggressive. And I think we're all like that. When we are put in a corner, whether you are the care worker or the service user, it's hard to be friendly and have compassion. You start to lose your temper. And on top of that, sometimes people can have dementia and they're confused and all that. And they have this conversation with the manager of the care agency. And they are like arguing with them, and obviously they don't see them. They don't see the manager. They only see the carer. So everything goes to the carer. So it's a very complicated thing because in a way they have a lot of fondness for the carer, obviously, because it's a really intimate relationship that you never. I mean, we don't have this relationship with anyone else, So it's something very personal. But at the same time, there is a reality of life and the frustration. So it's a really strange combination of things. But then the goal is to stay calm and to try to be wise. But then when yourself start to be tired as well, and you're starting to get into arguments with people, so it's a bit explosive. So yeah, it happens very often.
Any more questions from anyone in the crowd? Richard.
Thank you. Thank you very much for what was an excellent film. I think one of the things that really struck with me was the speed versus slowness that you really captured there, the frenetic life of the carer and the slightly slower life of those that were looking after, that clash and that tension from those very regulated visits. My question in making into your next project is, through the pandemic and the lockdowns and the challenges that presents, I wondered what your reflections would be on if you ran the film again, what you would you change or add anything to it based on some of the challenges of isolation that we've seen. We ran a report recently where we spoke a lot to people with dementia and their carers. And one of the really interesting things was a lot of people actually brought some of their relatives out of care based on some of the challenges that they were facing, brought them into their own homes. But that was very disconcerting for those individuals, that change and that upheaval at a very short basis. I remember speaking to one lady, her reflections, she was a mum, she had 2 or 3 kids, and she brought her mum into her home. And the level of change that presented and the uncertainty that created was just so significant that it basically had that whole life to basically come to a real sort of break. It was very, very tough. So I suppose my sort of overarching question is, what do you think if you ran the film again, you would sort of update or change or really sort of focus it on based on the pandemic?
I'll just repeat again for the audience. The question was really about the tensions in the film and what might change if the film was updated 2 years on, having had now 18 months to cope with the pandemic.
Yeah, well, like I said, we shot the film in December 2019, so that's why I added in that little bit of radio to make it seem like it was maybe January or February. But of course, the pandemic has completely opened people's eyes to, well, it did for a brief moment, to the value of care work. And, you know, but it's one of those flash in the pan kind of things. I got really excited. Wow, people finally care and value and realize how important this job is and how we don't recognize it. But you know, it just came and went, that idea. I think it would be a really different film now because, of course, COVID is such a big part of those people's lives, the most vulnerable people's lives, and care workers' lives. So I think, I mean, COVID would be a running theme, and the masks, you know, and the PPE, you know, that level of isolation would be even more heightened. But I'm so grateful that we did manage to shoot it just before, because it would be really hard to do it now. It would be dangerous. So, yeah.
Any more questions? We've got time for a couple more, I think. People have them. I'm sure there's one out. For like an auctioneer with a final kind of hammer coming down. There we go, there's one.
Congratulations. So, thank you. Congratulations. Really powerful film. Really resonated with me. I had an aunt. She was an aunt. She died around the time we were making the film. So, but what was interesting for me was, and this is one for Pierre, the care system is not ideal. So the questions about how long would have felt respectful, acceptable, because my aunt's case, her carers were very good. I think we probably had an hour, and that extra 15 minutes kind of made the difference actually. So they had time to talk to her. A dozen of them came to her funeral. You know, they were friends, and that happens obviously. But just that question of, is the gap such a narrow gap between your experience, which was really horrible, and my aunt's experience, which wasn't great, but it was so much better.
So just for the virtual audience, the question was, how long is long enough if we're thinking about care visits, and what kind of difference of, you know, extra.
I had an amazing relationship with the people I care for. And some of them, I think about them still now, almost like friendship, you know, like you want. So this is the reality. The problem is when is in between, it's not black and white, obviously. But for example, you're doing your day, and then suddenly you receive a call, someone says, for men it's slightly different in the sense there is less men carer. So you tend to have the schedules you really huge, the number of visits I had to do in the day, a lot of visits. But they would call me, they would say, oh, can you do this shift now? It's just next street, it's just half an hour, and you go there and you have no idea who you're going to see. And you don't know what you're supposed to do because they have these logs where you have all the instructions, this is under the bed somewhere. And so this is the problem. The problem is not really creating good relationship with people. I think this is always possible. The problem is to sustain that. This is a challenge. And I think London is different as well than maybe, I don't know where you live, but it depends on that. Because here, if you pay half the minimum wage, it's a life of development. You have the London rents. So you have to do even more visits. So you see, this is a pressure. But I think there is always good relationship. It's always possible. I hope I answered your question.
Sean, I think that was a hand, and it might be our final.
Thank you. I just wanted to ask what you thought the incentive was for the care providers and managers to change the system, because where it's set up, that the burden is on the carer in terms of bearing the brunt both of the displeasure that they're caring for, but also making up the time, and it really, it's not their fault, but it's them who has to solve the problem. So what would it take for the providers to think, actually, we need to do something better than this?
I think the person in the office is not a bad person. I think they're in the same situation. Most of the people in the office were carer before. When you start the job, they tell you, the first question is that they say is, what is your plan? What you are planning to do? As if being a carer has to be as temporary as possible. I need to find another plan quickly. And I was like, why that? At the beginning, I was very naive. I just wanted to do that and do my photography. And everyone had a plan already, because the goal is to go there, make the best of it in terms of opportunity, and then move on. Because it means that it's not sustainable. But then you move to the office. This is the route, you know, you become a carer and then you move to the office. But the person in the office in the terrible position, he has to make the schedule. He has to feed you, to feed all the visits, which is technically impossible for him. So he keeps trying to sort out the schedule. At the same time, people call him, like the elders calling him, because they're not happy about it. So it's like a vicious circle. So the people in the office have to have obviously more, more carers, but people quit. So it's like a vicious circle. And I think everyone is in the same situation at the end of the day. I don't think there is a bad person and a good person. It seems like a hopeless situation. I mean, from my experience.
So just to finish off, so I think that's been huge thanks for sharing your stories, sharing your story as well. Yeah. I wanted to finish asking, is there the Film 4 project, do you have a timeline or release date that we can take away, put in diaries?
Well, first they have to like my script, and if
Okay,
they do, then I'll get to shoot the film. But that probably be sometime next year. So probably won't be finished for a couple of years.
Cool. State of Health and Care 2023. We'll have you back and we'll share that. No, a massive thanks for talking that through and sharing. And a big thanks to everyone for coming and for staying through. I think we've had some fascinating conversations. So as you take it back, you can talk about that initial powerful conversation on inequality, on Matthew Taylor's anecdotes and slideshow mishaps and brilliant reflections on the state of the NHS. Lord Gus O'Donnell challenging us to think broadly about wellbeing, and then fantastic panels on the big challenges for the workforce, for the NHS, for social care, that combined the kind of optimism of the landmark moment we're in with the reality of the challenges that we face. I think that's a really interesting friction for us to take forward, and as a sector challenge ourselves to think about, to come up with things that are genuinely anchored in experiences and challenges, but also that present an optimistic vision of health and of care. That's certainly where IPPR wants to be and where we'll be taking it forward, and we want to talk to you if that's where you want to be as well. There's more drinks available, so we haven't had much of a chance yet to talk to each other, so do feel free to get a second glass of something, fruit juice, wine, and have a bit of a catch up. That's it for the formal events. A massive thanks, and we'll talk to you all again very soon, I hope. I should make one last finish, which is a thanks to the Health and Care Programme, IPPR's founding partners. So again, thanks to Gilead, Siemens, CF, AbbVie, GSK, that made it possible, and to our media partner for the day, the Health Service Journal, HSJ. So huge thanks to them. Yeah, it was really good.